ಬರ್ತಾ ಇದೆ ಆಡಿಯೋ, ಇದು ವಿಡಿಯೋ ಕ್ಯಾಪ್ಚರ್ ಕಾರ್ಡ್ ಹಾಕಿದ್ದೀನಿ.
ಇದು ಆಡಿಯೋ ಕರೆಕ್ಟಾಗಿ ಲೈವ್ ಬರ್ತಾ ಇದೆ ಇವಾಗ. ಆಡಿಯೋ ಆಡಿಯೋ ಬರ್ತಾ ಇದೆಯಾ?
इसमें मेरा है कॉपी का।
हेलो
Hello. Hello. Can you hear me?
हेलो रितेश. हेलो रितेश.
Okay.
आवाज आ रहा है क्या रितेश?
Hello.
हेलो. Can you hear me?
Yes.
Okay. Clear.
Yes, it's audible.
Yeah. Thank you.
ಬರ್ತಾ ಇಲ್ವಾ? Check. Hello. Mic check. Hello. Check test check. Hello.
check. Hello, Ritesh. Niranjan. Hello. Hello, Ritesh. Hello. Hello. Hello, Ritesh. Niranjan. Hello. Hmm.
A very warm welcome to everyone. Welcome to 2021. We are privileged to have you all here. We'd like to thank all of you for making it during this hard time of COVID. I request you all to keep your mask and follow the COVID protocols. So we are here to talk about total nutrition and total parental. So to talk about it, in 2020, million children died and 45 million to be 5 million were estimated to be weight and 38.9 million and 38.9 million were overweight under 5 are linked to undernutrition. We are privileged to- First speaker is Dr. Umesh. He's there to talk about the importance and indicate.
So there'll be a lot of interaction, and we can discuss absolute intricacies of the topic and we test by time. So now we don't have those two workstations. We have only one workstation. We have a lot of time to the end. The panel discussion, we can have an open forum, anything that we like, including the organization of this conference. So we will discuss. Here we'll have a very fruitful day. I was just telling everyone, meeting with just me being a single delegate, and I learned how to imbibe and learn. The left and the sit. It's an opportunity to we don't that learn. We'll have a quick interview. Each one.
Rajesh from unitology. Basically, I'm from the Mysore.
Kumar, neurologist at Ankura Hospital, Hyderabad.
Myself, Dr. Balaji, neurologist at Ankura Hospital, Hyderabad.
I'm Pratik. I'm working as associate professor of neonatology.
I'm Dr. Lakshman Basani, neonatologist from Ankara Hospital, LB Nagar, Hyderabad.
Veer Raghavan.
Amrita, I'm a lactation consultant at Cloud9 Hospitals, Pune.
Okay, good morning all. I'm Ketki Fala. I'm a TPN nutritionist working since last 12 years with Dr. Vaidya in KM Hospital, Pune.
Both these girls have worked with me for a long time. Absolute champions. Senior most lactation consultant in Pune, and they started lactation process when even this was an unknown specialty. So when we applied to the hospital said, "What is this lactation? We don't need anything." Our mother nurses manager, what do you need? So they started off their careers at a time when there was nothing like that. When the TPN nutrition hospital said, "What is TPN? Why do you need a post for that, position for that?" And we had to fight for it. They were paid, underpaid, not paid, but they. And today they are very well reputed Ketkis the only dedicated to TPN nutritionist in the country. Her job is only of lactation within the first hour of life is 100% compliance consistently for years. So there's the year night. So these people, they drive the mission, and you must have seen how Ketki was interacting with you, how they put the handout together in a record time. But Monday I told her, and Tuesday the handout was ready. Thanks to both of you, and it looks very, very good and brilliant. So I think they are a part of all workshops now, and they have a very long way to go in their careers. They have to create many more people like them because we need more and more TPN persons around to drive the mission.
Now once again, small letter J, capital letter J. पहले से start करेंगे. Start from first. Now here, sorry. J for chili. J for jam. J for joker. J for cake. J for jeep. J for jacket. J for jellyfish. J for school. Okay. Now see the next letter. J after capital letter K, small letter K. And what is this? K for king. King. K for king. What is this? K for king.
क्या देखें क्या साथ में
लेके आ रही
जल रहा है आवाज कम की है
बाकी घर की आ रही है गरम गरम क्यों लाके देती हो
बाहर आ जाओ यार।
Hello, we're not able to hear anybody. Can you please, admin sir, can you please unmute the host, whoever is speaking?
same lipid bottle amino acid can be used for many ways. So we give around 8 to 10 TPNs every day. So the
आगे है भाई
Okay, now after letter O, letter P will come. And this is capital letter P and this is small letter P. Now see that. What is this? Yes, P for piano. P for piano. P for piano. Okay. Now see the next picture. P for plate. P for plate. P for plate. Now see the next one. P for plate. P for plate. P for plate. P for pot. P for pot. P for pot. See the next one. P for pin. P for pin. Now what is this? Here for pin. P for pot. And P for pin. Now see the next one. P for potato. P for potato. P for potato. P for pineapple. P for pineapple. And P for pencil. P for potato. P for pineapple. P for pencil. Now repeat after me. P for piano. P for plate. P for pen. P for pot. P for pin. P for potato. P for pineapple. P for pencil. अभी सब लोग अच्छी तरह से अपना लोग बैठे कोई भी रिपीट नहीं कर रहे टीचर के पीछे ऐसे ही देखते बैठे हैं सब लोग एवरीबॉडी ओपन योर माउथ टीचर भी अगर चुपचाप बैठ के मुंह बंद करके तो चलेगा क्या नहीं टीचर किसके लिए पढ़ा रही है आप लोगों के लिए आपको आना चाहिए इसीलिए करेक्ट ना रिपीट आफ्टर मी मेरे पीछे रिपीट करो सब लोग ओके नाउ आफ्टर लेटर सी सॉरी after letter P, which letter will come? Q. Now here. Here. Letter Q. Which letter Q? Here. Now here. Letter Q. Q for white. Q for white. Q for white. Q for white. Now, the next picture, Q for queen, Q for
Hello, sir. Sashidhar, sir. Veer Raghu, sir.
Oh, hi.
Naveen, sir.
Dr. Balaji.
Oh, hi. Nice to meet you.
Very poorly organized, sir. Audio
I
and
expected all this.
No, it's not available in India. Sodium glycerophosphate is available in the West, which is routinely used. But here, I think it's an adult preparation. The dose is 0.5 ml per kg. Some have mentioned 1 ml per kg also. It contains vitamin A 1000 units, and it doesn't contain vitamin K, which has to be given separately. In the West, you have two preparations, solute and the other is fat soluble as well as water soluble vitamins are available separately, 1 ml per kg and 4 ml per kg. But unfortunately here we have only one preparation and we add to the lipids. Earlier we were adding to the amino acid preparation. And trace elements, these are also not available regularly, like salicyl is off, sometimes it's not available. And recently we started using this actually, though there is not much of difference between the two preparations. So Otski costs around 170 rupees. It contains 5 trace elements: chromium, copper, manganese, zinc, and selenium. And salicylate also is the same. The dose is 1 ml per each 100 ml or 0.2 ml per kg per day of. And carnitine especially is added if you are giving TPN for a long time, like for more than 4 weeks. The dose is 10 mg per kg per day. The IV preparation is available, Carnisure. The NICE guidelines doesn't recommend carnitine, but for babies who are on long-term TPN, like those, especially the surgical babies, I think are candidates for. And heparin, again, NICE guidelines doesn't recommend adding heparin, but we add heparin routinely. We use 0.5 units per ml, and it helps in. It has two advantages. One is patency of the central line, and the other thing is it stimulates endothelial lipoprotein lipase, helps in better clearance of triglycerides. And sir, what is your practice, sir? Like heparin? Okay. Yes. So we recently for a baby we it doesn't recommend we didn't give heparin, and within 1 week the PIC line was blocked. In yeah, it started adding. Yes. Yes, yes. 0.5 units per each ml. So this is from Turkey. The effect of low dose heparin on central lines. They infused at 0.5 international unit per kg per hour, which is through the PIC lines, and it reduced the catheter occlusion without any adverse effects like IVH and bleeding. And this is the laminar flow workstation which I bought in 2007 for using TPN. And these are all the constituents and the manufacturer and the cost. Next one. Total comes to, especially the filters are expensive, comes to around 3,500 rupees per day. And there is a discrepancy between the calculated and the measured osmolarity. So do you routinely check the osmolarity in your place? Okay. But we should not exceed this through the peripheral line, central line. So it's not an issue because of rapid dilution, hemodilution, it's not an issue anymore. So this is the 30 weeker. I was giving TPN with lipids through the PIC line from the left fossa. And always I used to connect, and I never used to allow anyone even to handle the baby. Every day I used to prepare TPN, even if it is Sunday 1 a.m. also. Next. Next one, please. So initially I was adding to the amino acid dextrose preparation, the yellow color vitamins, and this is the lipid preparation. Here we started TPN through the peripheral line. So we should always prevent from light, even the ambient light, sunlight, as well as especially the phototherapy lights, which cause degradation of vitamins as well as peroxidation of lipids. And the aluminum foil, again, NICE doesn't recommend aluminum foil because there will be gaps and all. Invariably, I think there will be some gap. And Vigon has come up with opaque tubings, electrogard. Again, I heard it's not available because of some issues leaching of that chemical, or maybe it's not very breakable, or I don't know what is the reason they have withdrawn from the. This is a 26 weeker 760 grammer on with RDS, was on conventional move. G5A4 PPROM, no antenatal steroids. Had to ventilate this baby for around 10 days. This baby has a PIC line. This is in 2008, sir. PIC line and TPN and lipids. And this baby at 7 months, the growth was so appropriate. This is the baby at 7 months. Next one. TPN has to be from sunlight as well as the phototherapy light because of peroxidation and oxidation of lipids, as well as vitamins, especially vitamin A and E, and these polyunsaturated fatty acids are very photosensitive. So right from the preparation till the delivery of parenteral nutrition, that has to be shielded from the light. And of course, aluminum foil is not recommended, but do we have any better alternatives for shielding? So for syringes, we use that black plastic paper, which is very opaque. But for the lines, we are still using the aluminum foils. And we should always be cautious regarding the content of aluminum in the parenteral nutrition. The safe limit is 2 mics, but most of the TPNs have been found to have 6.6 to 10 mics of per kg per day of aluminum, which predominantly comes from the calcium preparations. Next one, please. Inorganic phosphate, trace elements, any glass bottle during preparation is contaminated with aluminum. So almost it's a part of preparations. Next one, please. So to conclude, the composition and constituents of parenteral nutrition still are evolving and have to be improved. And there is a need for standard TPN bags in India, which reduces this preparation, and it also helps in early start of parenteral nutrition. So having at least 2-in-1 bag in India is very important. And still some of the constituents are not available in India, like organic phosphate, the pediatric MVI, parental zinc. And we need to reduce the contamination by aluminum. And I think the hospital pharmacies, especially in tertiary care hospitals and teaching hospitals, should take responsibility of preparation of parenteral nutrition. And the fear of infections, complications, and the cost are easily offset by the benefits of early optimal nutrition and the long-term outcomes. Main limiting factor I see is the commitment. That's a single most important thing. And cost is never an issue. Like we give nitric and high frequency, all are so expensive compared to that the cost of TPN. And if you give proper TPN, you even cut short the duration of stay in the hospital. So ultimately, it's beneficial, and the positive impact it has on the society is cannot be measured. Definitely, it has got advantages. There's no doubt about it. Thank you. Thanks. Thank you, sir. Thank you, sir. Thank you, sir. So recently we had a 35-weeker diaphragmatic hernia of the right side. Baby was very sick, was on high frequency 5 days, and surgery took almost 5 hours. When the baby was back, we started TPN with lipids from start. And at the time of discharge, at exactly on day 20 of life, the baby was 2.6 kilo. Birth weight was 2.2. Discharge weight was 2.6. Thank you, sir. Thank you very much.
Hello. ಡೆಫಿನೇಷನ್
ಒಂದು 5 ನಿಮಿಷ
ಟೆಸ್ಟ್ ಸ್ಪೀಕರ್ ಪಕ್ಕ ಇದೆ ನೋಡಿ, ಮೈಕ್ರೋಫೋನ್ ಅಂತ ಇದೆ, ಒಂದು ಹೆಡ್ಲೈನ್ ಇದೆ ನೋಡಿ. ಆ ಟೆಸ್ಟ್ ಮೈಕ್ ಪಕ್ಕದಲ್ಲಿ ಇನ್ನೊಂದಿದೆ, ಅದರಲ್ಲಿ ಲಾಸ್ಟ್ ನೆತ್ಕೊಳ್ಳಿ, ಡಿಜಿಟಲ್ ಆಡಿಯೋ ಇಂಟರ್ಫೇಸ್ ಯಾವ್ದಿದೆ? ಅವ್ರದ್ದು ಮುಗೀತಾ? ಅವ್ರದ್ದು ಮುಗಿಲಿ, ಸೆಟ್ಟಿಂಗ್ ಚೇಂಜ್ ಮಾಡಿ. ಚೆಕ್. ಹಲೋ ರಿತೇಶ್.
वॉइस
अभी आ रहा है, देखो. चेक. हेलो, 1 मिनट. हेलो. हाँ, बन्नी सर, 1 निमिष. हेलो, चेक. 10 सेकंड्स डिले रहेगा सर. 1 निमिष कैमरा इकड़े चेक. अभी देखो अभी उसमें सर. हेलो. हाँ सर, चेक. हेलो. हाँ सर. ಇಲ್ಲಿ ಇಂಟರ್ನೆಟ್ ಯಾವುದು ವರ್ಕ್ ಆಗ್ತಾ ಇಲ್ಲ ಇಲ್ಲಿ. ಹೌದಾ? ಇಲ್ಲಿ 1 ನಿಮಿಷ ಚೆಕ್ ಮಾಡ್ಬಿಟ್ಟು ಬಂದ್ಬಿಡ್ತೀನಿ. ಇಲ್ಲೇ ಅದು ಇಂಟರ್ನೆಟ್ ಇಶ್ಯೂಸ್ ಇದೆ.
ವಾಯ್ಸ್ ಕ್ಲಿಯರ್
ನೋಡಿ, ಚೆಕ್. ಬ್ರೋ, can you hear me?
Yes, I can hear you. Voice is clear ಇದೆ voice.
Yeah, thank you bro.
ಅದಿದು ಮಾತಾಡಿದಾಗ ಸ್ಕ್ರೀನ್ ಮೇಲೆ ಫೋಕಸ್ ಮಾಡಿ.
ಓಕೆ, 1 ನಿಮಿಷ.
ಸ್ಕ್ರೀನ್ ಮೇಲೆ ಬರ್ತಿರೋ ಕ್ಲಿಯರ್ ಆಗಿ ಕಾಣಿಸ್ಬೇಕು.
ಇವಾಗ ನೋಡಿ, ನಾನು ಕಾಣಿಸ್ತಾ ಇದ್ದೀನಾ?
ಕಾಣಿಸ್ತೀರಾ?
ನಿಮ್ಮ ಹೆಸರೇನು?
ತನ್ವೀರ್.
ನಾನು ಇಲ್ಲಿ TPN ಅಲ್ಲಿ ಬಂದಾಗ ತನ್ವೀರ್ ಅಂತ ಕರಿತೀನಿ. ಅವಾಗ ಪ್ಲೀಸ್ ನೀವು ರಿಪ್ಲೈ ಮಾಡಬೇಕು, ತನ್ವೀರ್ ಅಂತ ನೆನಪಿಟ್ಕೊಂಡು.
ಸರಿ.
ನೀವೇನ್ ಮಾಡ್ಬೇಕು ಇವಾಗ? ಇದನ್ನ ಫೋಟೋ ತಗೊಳ್ಳಿ. ಪದೇ ನನಗೆ ಫೋನ್ ಮಾಡೋಕ್ಕಿಂತ ಫೋಟೋ ತಗೊಳ್ಳಿ. ಇದು ಇದೆರಡು ಏನೇ ಇಲ್ಲಿ ಬರ್ತೀರೋ ಕಾಣಿಸ್ತಾ ಇದೆಯಾ? ಅದು ಕೊಡಿ. ಇಲ್ಲಿ ಬನ್ನಿ, ಸ್ಪೀಕರ್, ಹೆಡ್ಫೋನ್ ಅಷ್ಟೇ, ಮುಗೀತು. ಎಲ್ಲ ಯಾವ ಆಡಿಯೋನು ಎಲ್ಲೂ ಹೋಗಲ್ಲ. ಇಲ್ಲಿ ನೀವು 2 ಸೆಟ್ಟಿಂಗ್ಸ್ ಇದ್ರೆ ಏನೇ ಪ್ರಾಬ್ಲಮ್ ಆದ್ರೂ ನಮ್ಮ ಪ್ರಾಬ್ಲಮ್ ಅಲ್ಲ. ತನ್ವೀರ್, is it clear now?
It is clear.
Thank you, bro.
Voice is clear.
Yeah, thank you.
क्या हो गया? क्या हो गया बच्चे? क्या हो गया? नमस्कार.
एक तो उसको थोड़ा सा खांसी हो रही है और पेट में ना मतलब ऐसा हो रहा है, लस टाइप में हल्का सा ब्लड भी मतलब ऐसी चिकनी टाइप की लगती है.
हेलो तन्वीर. हेलो तन्वीर.
Please tell me now. Yes.
हेलो तन्वीर.
I am able to
ಬರ್ತಾ ಇದೆ ಹೇಳಿ ಅಲ್ಲಿ.
ಡಾಕ್ಟರ್ ಅಮಿತ್ ಸುಯಾಲ್ ಅಂತ ಬರ್ತೀವಿ.
ಅಮಿತ್ ಸೋಯಲ್. ನಾನು ಅಮಿತ್ ಸೋಯಲ್ ಅಂದ್ರೆ
ಇಲ್ಲ, ಅರುಣ್ ಇಲ್ಲ, 2 ವಾಯ್ಸ್ ಬರ್ತಿದೆ. ಅರುಣ್ ಅಂತಾನು ಬರ್ತಿದೆ, ಅಮಿತ್ ಸುಯಾಲ್ ಅಂತ.
ಅರುಣ್ ಅಂದ್ರೆ
ಅರುಣ್ ಬಂತು
ಈ ಮಿಕ್ಕಿದವ್ರನ್ನೆಲ್ಲರನ್ನು ಮ್ಯೂಟ್ ಮಾಡ್ಬಿಟ್ಟು ಅರುಣ್ ಮಾತ್ರ ಅನ್ಮ್ಯೂಟ್ ಇರ್ಲಿ. ಯಾರನ್ನು ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಬೇಡಿ, ಅರುಣ್ ಮಾತ್ರ ಅಲ್ಲ, ಎಲ್ಲರನ್ನು ಮ್ಯೂಟ್ ಮಾಡ್ಬಿಟ್ಟು ಅನ್ಮ್ಯೂಟ್ ಅರುಣ್ ಮಾತ್ರ. ಬೇರೆ ವಾಯ್ಸ್ ಎಲ್ಲ ಬರ್ತಾ ಇರುತ್ತಲ್ಲ, ಅದ್ ನೋಡ್ಕೊಳ್ಳಿ. ಓಕೆ. ತನ್ವೀರ್. ತನ್ವೀರ್.
ಹಲೋ, ಎಸ್ ಹೇಳಿ.
ಹಲೋ.
ಹಲೋ,
ನಾನು ಚೆಕ್ ಮಾಡ್ತೀನಿ. ಒಂದು ಬುಕ್ಲೆಟ್, ಇನ್ನೊಂದು ಆ ಕವರಲ್ಲಿ ಫೋಲ್ಡ್ ಆಗಿತ್ತಲ್ಲ ಅದು.
ಪವರ್ ಸಾಕೆಟ್ ತಗೊಂಡು
So welcome back, everyone. We have our next speaker, Dr. Hariram. He'll be talking about TPN protocol. Thank you, sir.
Good morning, everyone. Thank you, Umesh and Dr. Veeraraghavan, asking me to deliver a talk on TPN protocols units. I'm going to discuss in brief about the following parts. One is timing of TPN, duration of TPN, route of administration and meaning of TPN, amino acids and lipids, how much to start, how to advance, and for how long. Is there any scientific basis for this? Multivitamins, calcium and phosphorus in brief. Dr. Lakshman has already alluded to. Trace elements in brief. How do you administer TPN? A little bit about calculations, TPN related issues in India, and what are the dogmas, myths, and realities related to TPN in India. Early nutrition should mimic intrauterine environment, which Dr. Umesh mentioned in the beginning itself. You have to provide adequate amino acids for protein accretion, for positive nitrogen balance, adequate glucose delivery, adequate lipids, optimal nutrition to prevent catabolism or metabolic shock, avoiding postnatal growth failure or extrauterine growth restriction, which is very, very common
amongst ELBW babies. If the baby doesn't get adequate nutrition in the beginning, it can have long-term impact in addition to not achieving the short-term goals like short stature, organ growth failure, reduced neuron numbers, and brain-data connections also will get affected. So what are all the short-term goals you are aware of? Increase in the weight, get success, and then you plot on the Penton chart at weekly intervals and find out whether you are giving adequate optimal nutrition or not. Whether the baby is regaining birth weight, taking a longer time to regain birth weight instead of 10 days or at the most 15 days, preventing postnatal growth failure, decreased morbidity and mortality, which are definitely related to whatever nutrition you give in the beginning, and reduction of ROP, BPD, and necrosis and epilepsy all have a definite bearing on the way you give nutrition in the beginning, standardized feeding regimen, and early discharge. And then long term, most important thing is appropriate neurodevelopmental outcome. So the aim is to provide adequate protein and other nutrients to promote maintenance, recovery, or catch up of lean mass and the nutrient accretion. So what is the expected? Around 15 to 20 grams per kilo per day would be the growth velocity, and then head circumference is around 1 centimeter per week. So energy is necessary for resting metabolic rate, activity, thermoregulation, as well as growth. And this has already been alluded to. The proportion of calories from carbohydrates, protein, and fat roughly around 60, 30, 10. The idea is to prevent the proteins from getting broken down, oxidation, and not maintaining the protein positive balance. So energy requirement, if you give parental nutrition, is around 80 to 90 kilocalories per day. It will go up to 120 to 150 if baby is entirely fed. Two things you should be aware of: if you give less amino acids and high glucose, whatever protein you are giving will get oxidized, and then there will be negative nitrogen balance, and hyperglycemia can result. If you reduce the concentration of glucose, what I mean to say is, if you give optimal glucose and not a higher concentration of glucose and the greater amino acids like 3 or 4 grams, so there will be higher insulin secretion and normoglycemia. So you are aware of the requirements. Next
Is it available easily? It's a unit to take it. It's a unit to take it. Cell is but actually it's 2 weeks. Who knows you add this limits? We have after the first week. First week we get service cell. So 1 dollar per kilo of vegetables are this option. Course is that
हेलो चेक, हेलो माइक टेस्टिंग, तो जा रहा है क्या आवाज?
So see, you don't have parental zinc available. That becomes a problem. But most of these babies have given blood or plasma for some reason or the other. Most of these critical ones are giving blood or plasma. Plasma and blood give them some amount of trace element, though not enough. And if you are on TPN, you have started some amount of enteral fees. So there are limitations, no doubt. But as I mentioned, most of the things are available. You may not be absolutely perfect TPN, but you can be very close. So why you have some data? Yeah, quite a compare.
Good morning, everyone. I'd like to thank Dr. Umesh, the Ankura Group of Management, and all the staff for giving me this opportunity to speak about complications and monitoring. Till now, we have been listening to the benefits. I have been called to talk the other side of the coin, the complications. So we need a very fine balance to maintain to see that your drawbacks don't outweigh your benefits. And this can be done by monitoring. As discussed, complications can be offset by the benefits which parental nutrition gives, the long-term nutritional benefits which a child receives. So complications can occur when the child is receiving parental nutrition, which need to be addressed, and there are some long-term effects. So those that can happen immediately include those related to the formulations and those related to the infusion site, the central venous catheter, while the long-term effects can be hepatobiliary complications, metabolic bone disease, and growth deficiency and failure. So first we will be talking about the immediate ones that happen during the administration of parental nutrition. So most importantly, first we'll be talking about the complications related to the PN formulations. The first thing is stability. So issues with stability can happen because of your variations in pH due to different batches of glucose, and your calcium and phosphorus precipitations can happen when the variation in pH occurs. So there can be changes in trace element profile by either adsorption or latching onto admixture solutions or tubings. And these precipitates that have been formed can be decreased by the use of organic calcium gluconate and organic bound phosphates. But these preparations are organic bound phosphates are not available in India. These precipitates can be prevented from entering the catheter central line by using a 1.2 to 1.5 micron filter for amino acid solutions, and for lipids they usually recommend a 0.22 micron filter. So that is what the latest American Society of Pediatric and Enteral Nutrition paper recommends. So this is an air eliminating filter with a flow towards the patient with an air vent to remove air, whatever is there in the line. Drugs should not be mixed with the TPN infusion.
Have you reached the stage like anyone from online delegates?
Yes, this Dr. Rajesh,
Yes.
reached.
Okay, good. I think it's more of self-learning.
Vitamin C will get oxidized to oxalic acid, and oxalic acid can form precipitates within the tubing. The PUFA component in lipid emulsions can get oxidized, and amino acids like tryptophan and tyrosine are also photosensitive. Hence, it is recommended to cover the aqueous as well as lipid emulsions with photoprotective light. This is what is the recommendation. Next slide. The ideal site for delivery of parenteral nutrition is a central line. Peripheral line can be used for delivering TPN if the duration of parenteral nutrition, if the duration of parenteral nutrition is likely to be less than 5 days, if you have a delay in accessing a central catheter or central venous access is practically impossible. But it's better to keep your osmolarity less than 900 milliosmoles per liter. Studies by Dugan et al. In 2013 have shown that if your osmolarity is more than 1000, the risk of thrombophlebitis is comparatively high. Better have osmolarity less than 900 milliosmoles per liter. Then you have nutrient-related complications. So you can have dyselectrolytemia, hypoglycemia, hyperglycemia. These can be because of the clinical concerns in the baby, metabolic acidosis. It can be because the baby is sick. The baby is critically sick. The baby might have perinatal asphyxia, sepsis. So, or it can be because of errors, calculation error or a medication error. And to decrease calculation errors, definitely you have TPN softwares which are now available in our country. So that will cut down the calculation error. So hypoglycemia can be because of the clinical reasons, and any sugar that's less than 40 in the first day and then less than 45 should be considered as hypoglycemia. Titrate your glucose infusion rate, not going into the much detail about the calculations of GIR, and increase your GIR by 2, trying to keep the volume same. Hyperglycemia can be because of excessive it can lead to osmotic diuresis and subsequent dehydration, and it's important because it can cause intracranial hemorrhage and there is a high mortality associated with it. Decrease your GIR by 2, and if your blood sugar is more than 200, you can start insulin infusion at 0.05 units per 0.05 to 0.1 units per kg per hour. Metabolic acidosis. So metabolic acidosis can be because of the clinical concerns in the baby. If a baby has metabolic acidosis when the baby is receiving parenteral nutrition, look at the clinical condition. Does the baby have any sepsis? Other reasons related to PN formulations can be an imbalance between cationic and anionic amino acids. So excess of anionic amino acids as compared to cationic amino acids can cause, so cationic amino acids like lysine, histidine, and arginine, and anionic you have aspartic acid and glutamic acid. Presence of oxidation of sulfur to sulfuric acid in certain amino acids like methionine can also cause metabolic acidosis. Hyperchloremia is associated with metabolic acidosis if excess of chloride is administered through potassium chloride and sodium chloride. Hypertriglyceridemia, not going into the detail, already has been discussed in the previous sessions. Use of 20% lipid emulsion is preferable to 10% emulsion because of the less hypertriglyceridemia. Normally, we have 150 to 200 milligram per deciliter, that is normally acceptable. If your values are more than 200 milligram per deciliter, we definitely decrease the dosage of lipids, and values more than 265 stop lipids immediately. Around 10% of babies will not tolerate your lipid emulsions. Next, we check weekly. So we'll be coming to the monitoring. Then once you have seen these complications related to parenteral nutrition formulations, the other aspect is the complications related to CVC. They can be infections or mechanical complications. So infections are one of the most common serious complication, and they're a significant cause of morbidity. And consider all bloodstream infections in a child who has a catheter as CLABSI. So what are the risk factors? Prematurity, prolonged prematurity, specifically VLBW is less than 1500 grams. More the duration of parenteral nutrition, more the catheter is in situ. Presence of active intra-abdominal pathology, abdominal surgery in the prior 7 days, and male sex. Usually organisms isolated are gram-positive staphylococci, coagulase negative, coagulase positive, and fungi in some cases, and gram-negative bacilli. So send a blood culture. Usually it's advisable to send a paired quantitative blood culture from both the percutaneous route and through the catheter tip. And if you isolate the same organism, then you can say that the infection is related to the catheter, and you can classify it as catheter related bloodstream infection. The duration of antimicrobial therapy is 10 to 14 days with the sensitive antibiotics. Once you identify it's a catheter related bloodstream infection, the next most important question is, should we remove the catheter? Because some children require catheter for a longer duration, and venous access is sometimes practically not possible. So what we follow is, we remove the catheter if there is a severe sepsis, if there is a suppurative thrombophlebitis, and infection is with recurrent organisms. Infections is with virulent organisms, fungi, cons, and pseudomonas. If there is recurrent bacteremia, if you start your antibiotics, see for 48 to 72 hours, repeat a blood culture, and the blood culture isolates the same organism, it's better to remove the catheter. Catheter can be continued if the infection is with less virulent strains and there is improvement with empirical antibiotics within 48 hours. So coming to the mechanical complications, occlusion. First is the occlusion. Occlusion, we often find that the infusion line, it's not able to go. So it can be thrombotic and non-thrombotic. So non-thrombotic occlusions can be because of medication, crystallizations, and precipitations, while thrombotic occlusions need to be investigated and treated.
Good morning. Thank you for
registering for the TPN workshop. You have all the stalwarts to guide you in the knowledge and the skill of preparing and administering TPN. Many a times in the melee of cardiorespiratory stabilization, nutrition goes for a toss. So the earlier you start, the proper way you start, I think that gives a lot of strength to the baby and to withstand many of the stresses of the newborn period. Also, if given properly, it also gives the baby the required calorie, protein, everything. So please learn the proper way of giving TPN indications and everything, and practice it. And thanks to all the faculty here, Dr. Hariram, Dr. Shashidhar, all the faculty for taking time off and conducting this workshop.
All the best and happy learning to all of you, and all those are online. It's a very important topic, and the best faculty with you to teach TPN to all of you. All the best.
When you are conducting TPN, you should train your one of the staff. You can be skilled, because once you put the TPN, observation is very important. Thank you.
So coming back to the topic. So we have already discussed the role of heparin. Studies have shown that the duration of catheter patency and risk of thrombosis is decreased, but still the Cochrane review says not statistical difference was observed in the groups those received heparin and did not receive heparin. Once we see occlusion is the other common complication is extravasation. It can have life-threatening implications. It can lead to pleural effusion or pericardial effusion or a cardiac tamponade sometimes. Breakage that can be because of line clamping, direct trauma to the catheter, repeated kinking or attempts to unclog the catheter. Once you insert your central catheter, often it migrates sometimes into your neck vessels like the internal jugular vein or the contralateral brachiocephalic vein. So this is the latest approach which has been given by the ASPEN, which shows that if you suspect a CVC occlusion where your inability to infuse anything via the CVC, check for mechanical obstruction. Look at the site, look at the catheter, tubing and clamp, whether the clamp is removed or not. Sometimes you need to replace the CVC dressing that's too tightly placed. And if once all this is fine, look for patient malposition. Sometimes repositioning of patient itself can clear the occlusion. Look for any precipitates. Check your IV meds and PN components for incompatibilities. And if everything is okay, just confirm the position of the catheter on the X-ray. So these complications can be prevented by proper positioning, appropriate measures to secure the catheter, and education to the caretakers like nurses and the attending physicians for correct maintenance of central catheters. The ASPAN guidelines recommends that the CVC tip should lie outside the pericardial sac, and the rationale they have given is the pericardial reflection is 4 millimeters above and 5 millimeters below the carina. So it's better that your tip lies at least 0.5 centimeters above the carina on the X-ray. Once we address the complications that have been happening immediately associated with the CVC or because of the
overlook is when you put it PICC line in the left saphenous vein and it goes into the ascending lumbar plexus. The baby will have will end up with the paraplegia with long-term consequences. So that is something that is frequently reported in Western literature, and there is a clear-cut rule that don't use the left saphenous vein for putting your PICC line. And if you are doing so, then make sure that it is not in the ascending lumbar plexus. And based on just an X-ray, it is quite difficult to judge whether it is in the ascending lumbar plexus or in the IVC. So there is one complication that we are not frequently taught when while we are doing our training in India. Similarly, while using the upper limb PICC line, go for the medial basilar vein rather than the lateral cephalic vein. The chance of extravasation will be much lesser. So these are things that we need to be careful of. And we have included in the document that we have distributed to the delegates regarding PICC line and TPA. Sorry for the interruption at this moment. What is the incidence of this complication? Though the incidence is quite lesser, the consequences are quite severe. So the NHS, when they reviewed their data, they came out with their guidelines that left saphenous vein may not be used or should not be used. If you have other options, go for the upper limb PICC line or the right saphenous vein for accessing the PICC line. Though only few case reports are there because the consequences are quite bad for the baby, and we have other alternatives other than using the left sided saphenous vein. So NHS came out with a uniform protocol for all the hospitals, I mean all the NSUs. Even I got to know when I was training there, they frequently used to use all types of veins for accessing PICC lines, for inserting PICC lines. So how to make it? So but if you have put a left-sided PICC line, make sure it crosses the vertebral body and then ascends. If it is not crossing the vertebral body and it is ascending on the left side itself, then it is most likely in the ascending lumbar plexus. And you will have classical X-rays where you have the line taking a curl initially and then going up. So these are available, as case reports. You can see the X-rays. But left, it's a dangerous complication because once the lipid extravasate sits into the subarachnoid space, the baby is gone. It will be paraplegic.
We have to get later X-ray then to see the thing going down and then going up the lumbar plexus.
So next, moving on to the complications associated with long-term use. So the first is the hepatobiliary complications. The liver and biliary tree are responsible for detoxification and elimination of endogenous and exogenous lipophilic compounds and heavy metals. So most complications associated with liver are moderate and reversible. The spectrum can vary from, it can be just a biliary sludge to gallstones to cirrhosis and hepatic decompensation. So the term now we frequently use is parenteral nutrition associated liver disease, and elevation of bile acids is the earliest manifestation. While the biochemically you get elevation of alkaline phosphatase and GGT which precedes hyperbilirubinemia. The pathogenesis is unclear. However, both patient-related and PN-related factors have been known to increase the risk of penal. So, absence of oral feeding, prematurity, sepsis, and surgical conditions can impair your enterohepatobiliary axis and increase the risk of liver disease. Excess of total energy can induce liver lesions. Excess glucose intake can cause hyperinsulinism and subsequent steatosis. And as discussed already with the first and second generation lipids, the soya-based lipids, the increased content of phytosterols. So how, in these phytosterols, we have three: beta-sitosterol, campisterol, and sigmasterol. Sigmasterol is the most culprit that has been found. So what are these phytosterols? They're plant-derived sterols. They're structurally analogous to cholesterol, and they're highly found in lipid emulsions derived from that are vegetable oil based. And they are not fully metabolized by the body and excreted through the hepatobiliary system. So stigmasterol is often the culprit associated. It inhibits this nuclear receptor called FXR, and this inhibition of nuclear receptor FXR causes reduced hepatocyte expression of bile salt export pump, which is a major determinant of bile secretion. So this leads to your cholestasis. So what is the treatment? Early establishment of oral and enteral feeding will stimulate your enterohepatic biliary axis. Reduction of lipid dosage, but now you can use the newer generation lipids like SMOF. And ursodeoxycholic acid, the role is still controversy, has shown to decrease the biochemical markers associated with cholestasis, but before it's routinely recommended, we need further evidence. And as already discussed about the newer generation lipids, so not going into much detail. So penal can be prevented by minimizing the duration of parenteral nutrition and promoting early feeding and reduction of the total calorie intake. Use of fish oil containing based lipids may reverse penal. So children who are on long-term parenteral nutrition are often found to have metabolic bone disease. There can be reduced bone mass during adolescence. The reason behind is the aluminum contamination of TPN. Many formulations contain aluminum, and aluminum suppresses the enzyme 25-hydroxy-1 alpha hydrolase in kidney, thereby decreasing the active form of vitamin D3. And once your active form of vitamin D3 is decreased, it leads to lower calcium and hence demineralization of bones. So diagnosis, such children should be screened with bone turnover markers like osteocalcin, alkaline phosphatase, and every 6 to 12 months may require a dual energy X-ray absorptiometry. Treatment in adults, bisphosphonates like palmidronate have been associated with better outcomes, but limited evidence in infants. So this can be prevented by decreasing the amount of aluminum and regular screening with bone markers. Children who require long-term parenteral nutrition like short bowel syndrome or enteropathies often have been found to have growth retardation. Parental nutrition in these children not only has to achieve the nutritional goals, but it also has to maintain appropriate growth. Studies have shown that short stature, altered lean fat mass, and lower body mass index are common with children on long-term parenteral nutrition. Hence, they should be regularly followed up for growth and body composition monitoring, because altered body composition, as Barker has said, can lead to long-term metabolic consequences. So once we see the complications, we come to the monitoring. So monitoring is a continuous dynamic process. And as Dr. Umesh has already said, the establishment of a strong nutritional support team is very important. It helps you monitoring the baby vigilantly. So monitoring should begin in your daily rounds at the bedside to your biochemical monitoring. So what are the bedside assessments you can do? The clinical examination of the baby. It gives an overall impression, overall activity of the baby. Look for subtle signs like unexplained tachycardia. Anthropometric measurements, this is the recommendation: weight, head circumference, and weight daily, head circumference and length weekly. But sometimes your anthropometric measurements can be inaccurate if the child has developed edema. So your calculation of intake and output is very important. Then your nutrient intake calculations, energy and protein, energy in kilocalorie per kg per day and protein in gram per kg per day. Assessment of the infusion line, whether just have a look at the catheter lumen, the infusion site, whether the caretakers are following appropriate antiseptic protocols, and detect signs of infection at the earliest. So what we follow in our unit is documentation should be done at every shift for the catheter lumen and infusion. The patency of tubing should be checked. Look for any catheter kinking or extravasations. And the dressing needs to be changed if it's damp, loosened, or soiled. You can use chlorhexidine impregnated dressings for children greater than 2 months, but use of topical antibiotic is not recommended. See that the TPN is prepared appropriately under a laminar flow. The 6 steps of hand hygiene which need to be followed are being followed by the caretakers. And we follow this scrub the hep technique, where catheter connectors, ports, and hubs should be disinfected with your 2% chlorhexidine. You can have a CLAPSI bundle checklist that should be done with every shift, and that can reduce your rates of infection. Coming to the biochemical monitoring. So the general principles include: collect the minimum volume of blood. Most of these babies are preterm, and if it's better if you maintain a blood let down chart where you can appropriately assess the amount of blood that has been taken. So try to pool your blood tests, coordinate the time, and use a protocol that has been agreed with your local laboratory. So these are the latest NICE and SPAN guidelines. Not going much into detail, sugars, they say monitor whenever you change your glucose or whenever there is a change in TPN. Otherwise, you can, once stable, you can monitor it less frequently. Blood pH, potassium, and chloride. Initially, when you are increasing the TPN, they advise to do frequently. Otherwise, on maintenance TPN, you can do once or twice weekly. Some units don't practice doing serum triglycerides at all. What NICE and SPAN recommend is while increasing the dose 24 hourly, otherwise weekly, and liver function tests and your BUN and creatinine once weekly, while iron is recommended only if you have prolonged PN. This is a ready reckoner which can be formulated to your unit. So blood sugar, we follow 2 to 3 times a day when we are escalating the GIR, and once daily, once you are on stable GIR. Serum electrolytes, we initially do twice weekly, then weekly. Urea follows the same pattern. Liver function tests, we do weekly, and calcium, magnesium, and phosphorus, initially once every 1 or 2 days, depending on the clinical concern. If the baby has perinatal asphyxia or if the baby is preterm, your calcium monitoring may require. Simultaneously, if you find an lipemic blood sample, your serum triglyceride monitoring needs to be more frequent. Otherwise, it can be done weekly. So the children who are on long-term parenteral nutrition, the road ahead is very tough. We need to monitor for metabolic bone disease and also growth failure. So we need to have annual bone mineral density and growth monitoring every 6 to 12 monthly. Always remember, early detection of complications is better. Keep an eagle's eye. Assess the baby right from the bedside to your, if needed, biochemical monitoring. And definitely complications are offset in parenteral nutrition because the long-term benefits of parenteral nutrition are much better. Thank you for the talk.
If your TPN is going to be
partial, short term, you won't be using
high nutrients, the complication generally will be okay. So though we must be aware of everything, the complication should not put a fear in you that we should not do TPN. So as we were all discussing, Dr. Hariram, Dr. Lakshman, our units don't have much complication because we are aware of them and we know how to monitor. So those big list don't need to be scared. TPN, cholesterol and such things are not as common now as they were before. For better nutritional products and better experience in handling. Thank you. Workstations, and we have broken the talks into workstations so that we don't have a long prolonged lectures in the workshop. So we were initially going to split the group into 2, but we will avoid that and we will do it together only. And the first one is the most interesting one, that's the manual calculation. So whatever we are going to do, I think Dr. Chanchal is with me. So you know the case that we have. Okay. So I'll first take my specs.
Ready to worksheet and the calculator. Just before your software based calculation. Small request. Small request, please. Everybody in your groups, please put your double vaccination card. Double vaccination card is there. Please. You have a group, right? You have a TPN group. Who is not there in the group? Group, please, because now government people might come. They might ask you whether you can allow this vaccination or not. Before that, what you do? Please put it right. Okay, so we are ready. Workstations, manual software, and immediate touch. So after lunch, we'll have 2 more workstations. So KT has prepared a case, and the company is going to present that on the screen. We write that day of TPN is 5. And what's the day of life? Day of life is 5, day of TPN is 5, and the weight of living 1 kilo. So it's easy for us to calculate. So put it in the box on the right of the form. The projections are begin. Ashish, A5, 1 kg, 80, how much food I understand what will be the total fluid volume that you want to be saved? At A5, 1 kg. 150. So most of us will be 150 available reason. So it will be 150 multiplied by 1. It will be total 150 ml per day. So the answer to 1 is 150 ml per day. That's the normal calculation that you do for live fluids. This is very free.
This is not on feeds for some reason. So we say that TPN volume 150 minus feed volume, that is 0. So the TPN volume remains 150. And this baby does not have any losses, but it's not a surgical baby. So the losses also are 0. So the total TPN fluid volume and TPN volume remain the same as 150. I must add here that whenever you add small amount of feeds like 1 ml 2 hourly or 1 ml 4 hourly, you may not minus them from the TPN because that baby can go NBM anytime. So if you minus the feeds and suppose the baby is put NBM, your TPN will be finished before time. That's why what we do is unless you have reached a substantial amount of feed, we do not minus it from the total volume. So this total volume also remains 150. Now we want to ask, I think you're next to you, how much fat would you like to give this baby? Grams per kg. This baby is day 5 and baby is relatively stable. Yeah, so 2.5 to 3. Okay, so how much would you like, 2.5 or 3? How much would you like, 2.5 or 3? 3. Okay, how much have you taken? Okay, so She has put 3.5, you said 2.5 to 3.5, according to me, it's okay. So let us, for the sake of this calculation, take that value as 3.5, just because we're just doing a calculation. 3.5 multiplied by 1, and we are going to divide it by 0.2 because we are using 20% interlipid. So you can see 3.5 multiplied by 1, that is 3.5 divided by 0.2 because 20% interlipid comes to how much? 17.5 will be the fat volume. Chanchal, tell us when you're ready. Yeah? Now, the next step is called as hyperalimentation solution volume, which means the total TPN volume that was 150, we minus from that the feed volume, which is 0, and we minus the fat volume, which is 17.5. So that comes to how much? $132.5. So from the total fluid volume, you minus the feeds, which was 0, and minus the fat volume also. There are a lot of people who do not deduct the fat volume. So they say that we don't want to deduct fat volume. Some people say we deduct half the fat volume, not the total. But in a small baby of 1 kg, it's better to deduct that volume because that 17.5 ml is a big volume for a small baby. So we do deduct fat volumes from that, and we get a total volume of 132.5. This volume is now available for the amino acid, everything together. So if anyone has any problem at any stage, just interrupt there only, because otherwise the next step will be confusing. Fat volume, you said 3.5 gram per kg multiplied by 1 kg divided by 0.2. 0.2 because lipid concentration is 20%. So it will be 3.5 into 1 divided by 0.2, which will be 17.5 ml. Yeah. So if there are antibiotic boluses, dextrose boluses, you've given plasma, is on dopamine, dobutamine, all that will have to be minused. Now, in the software, you'll see that the software asks you, are you giving dopamine, dobutamine, arterial line, at what rate? So the software automatically will minus all this, because it asks you, are any other infusions being given? There you can put these figures, and then you don't have to calculate. The software will minus all that from you. Okay, but here we have to do it. We are doing it manually, because unless you know it manually, you don't know how the software works. So first, let's do it manually. It's slightly tedious, but when the software will do it literally in 5 minutes or less than 5 minutes. So let's go through this process. When computers came in the early 90s, my boss used to always tell me, ये काम बहुत urgent है, manually करो, time ज़्यादा है तो computer use करो. But we were struggling with the computers. So my boss used to say, manually करो, ये urgent है बहुत, जल्दी करो. Yeah, so those days we were very new with computers, and we made a lot of mess with it. So the boss used to get very angry if you use the computer. He said, manual jaldi ka hota hai. Okay, so now we come to the next step, that we have said the hyperalimentation fluid volume is 132.5. Is that right? Okay, fine. So Ketki has taken fat as 3 instead of 3.5. So her figure has come to 135. So we'll keep it 135. Now what happens is we need 135 ml of fluid. But as all of us, we are aware that when you infuse this 135 ml, a little bit always stays in the bottle and some amount stays in the set. We can't infuse to the last drop. So you always have to make 20% more than what you actually need. So if you have made 135 ml is your requirement, then you are going to make more 20% to account for the amount of fluid that's left in the bottle and the tube at the end of the infusion. Because tube, even when you remove the IV line, some amount of fluid is there. So that overfill, which is written there in step 5, accounts for the additional fluid that we have to prepare, so that there is no shortfall for the amount left over in the bottle or in the set. So we say 135, we want 20% more. So that, and so we divide 135 divided by 0.2, which comes to so it comes to 162. So we need 135, but we are making 20% more. So we need 162, because then out of 162, we'll infuse only 135, and that remaining 27 will be in the bottle and the set. So that, and when you do this overfill factor of which is 1.2, 1.2 means 20% more. You have to multiply everything by 1.2 because everything that you add in it has to be 1.2%, 1.2 of the total amount calculated, because that 20% is going to go waste. Okay. Step 6.
And that is 162. So 162 capital B by A, what is that?
Factor B is, I think, order, volume order is 135.
See, that factor is actually fixed. So the range of that factor is 1 to 1.2. It is 10 to 12% extra of your total volume.
No, what she's trying to say is that.
So I already calculated 20% extra. So the volume was 125 and 20% extra is 27 ml. So that is it.
So what she's trying to say is if you divide 130, multiply 135 by 1.2, you will get 162. So 1.2 is your overfill factor.
So instead of doing that separately, 135 plus 20% extra, which comes to 162, I can do 125 into 1.2, that will come to 1.
Correct. So correct, absolutely correct. So what we do is that 1.2 is called as the overfill factor. That's B by A. That's the overfill factor is 1.2. So you can call it anything. Essentially, it means 20%.
Yes.
So let's say we want to take the next step. 6th. So now we have to come to step 6. So now we have to calculate all the constituents of TPN. So first is amino acid. So as we have decided, we have just projected this case scenario. So in this one, we have decided to give amino acid at 3.5 gram per kg per day. So, and weight of the baby is 1 kg, 1000 gram. So if you calculate this one, you put amino acid 3.5 gram per kg multiplied by weight, which is 1 kg, and then overfill factor is 1.2. Okay, because we are preparing 20% extra. So multiplied by 1.2 divided by concentration, which is actually multiplication factor based on the concentration of the constituents which we are going to use. So we are going to use 10% amino acid solution most of the times. So we have to divide by 0.1. 10%, so we have to divide by 0.1. Okay, got it? 10% is 10 gram per deciliter, so 0.1 is the multiplication factor here. So just calculate how much is it? Okay. Okay. So the concentration is multiplication factor here. Overfill factor is B by A, which is 1.2 since we are preparing 20% extra. So this follows for all the constituents. So now next one is sodium. Sodium, how much you want to give? As the slide says, 3 milliequivalent per kg per day. Okay. So yeah. So here you write 3.5 milliequivalent per kg. Oh, sorry. Yeah. Is the multiplication factor. So sodium, I'm sorry, this is the milliequivalent per kg. So write down milliequivalent per kg. So 3 milliequivalent per 3 milliequivalent per kg sodium, then multiplied by 1.
1 kg, multiplied by overfill factor 1.2, then divided by, as sir said, if we are going to use 3% saline, then multiplication factor is 0.5. So divided by 0.5. Calculate how much is it? So this much ml of 3% saline to be added. If you are using another sodium solution, then as sir said, the multiplication factor will be different, 3.3 for the other solution. Next one is potassium. So potassium you want to give at 2 milliequivalent per kg per day. Okay. So in the first column it is 2 milliequivalent per kg per day, multiplied by 1 kg, multiplied by overfill factor 1.2, and then divided by, now you have to decide multiplication factor. So what potassium solution we are using commonly? So KCl, 15% KCl solution, which 1 ml contains 2 milliequivalent. Okay. Okay. So so divided by 2. Divided by 2. Multiplication factor is 2. Got it? So 1.2 ml KCl solution. Next one is calcium. So calcium again, here we have mentioned 2 milliequivalent per kg per day. Okay. Many of us use calcium gluconate and we calculate in milligram per kg per day calcium. So you have you should know the multiplication factor. Here we are giving 10 milliequivalent per kg per day. So multiplication factor in milligram per kg per day is 20 for calcium. So here we have mentioned 2 milliequivalent per kg per day. That comes to 20 into 2, 40 milligram per kg per day. You can calculate either ways. I'm just giving one example. So if you are calculating in milligram per kg per day, multiply this one by 20. Okay. So I will come to that. We have to. This is for all the constituents. So calcium, suppose you are calculating in milligram per kg per day, you write multiplied by 20, so 14 milligram per kg per day. Or if you are just using this milliequivalent per kg per day, then just like 2 milliequivalent per kg per day, multiplied by 1, which is birth weight, baby's weight, and then multiplied by overfill factor, which is 1.2, and then multiplication factor. So multiplication factor is 2 here for calcium. How much is it coming? Oh. Yes. 10%. 0.45 milligrams per actually 0.45. So idea is, and you should know the idea basically. We can calculate in milliequivalent per kg per day also. Suppose you are calculating in milligram per kg per day. So 40 to 2, 20 to 2, 40 milligram per kg per day. And then multiplied by birth weight 1, multiplied by 1.2 overfill factor, and then calcium concentration. So calcium concentration, suppose if you are using calcium gluconate, 1 ml contains 9 milli. Okay, so 9 milligrams, that will be 9. If you are using in milligram per kg. But if you are using milliequivalent per kg per day, the concentration factor will be 0.4. Yes, 5.3. Yes. Next is magnesium. There can be confusion in the unit of the constituent. Okay, so don't be confused with the unit of the constituent. You should know the idea. So idea is same, like this is for all the constituents. The amount which you are going to give, multiplied by weight, multiplied by overfill factor, and divided by multiplication factor, which comes based on your constituent solution which you are going to use. Then for magnesium, So magnesium here we have mentioned 0.3 milliequivalent per kg per day multiplied by 1 multiplied by overfill factor 1.2 and then divided by multiplication factor is 4 here because 1 ml contains 500 milligram of magnesium. Okay, that is equal to 4 milliequivalent of magnesium. So that's why 4 is the multiplication factor. Just to remember easily, 1 ml contains whatever amount is the multiplication factor here. So suppose for KCl, 1 ml contains 2 milliequivalent. That is 2. 1 ml contains 1 ml of calcium gluconate contains. So multiplication factor is 9. Okay. Yes. In milliequivalent it is 0.45. In milliequivalent, so this is 0.45. In milligram it will be 9. Okay. Same for magnesium also. So magnesium, if you are calculating in milligram per kg per day, then 500 milligram. But if you are calculating in milliequivalent, 4 because 1 contains 4 milliequivalent of magnesium sulfate. You got the idea? The next one is MVI. So how much is the magnesium? 0.01. Yes. Next is MVI. So MVI we have seen this is to be given at 1 ml per kg. Okay. So 1 ml per kg multiplied by 1 and overfill factor is 1.2. There is no multiplication factor over here. Okay. This is universal for all 1 ml per kg. So how much is it? 1.2. And last one is heparin. So heparin. Just calculate. If you add all these, it will come to 50.9 ml. These are additive volumes. This does not contain dextrose. Now, still we have not calculated dextrose. This is the major source of energy. So now we are calculating dextrose in step 7. Okay. So in step 7, we have to calculate first how much volume of dextrose to be given. Okay. So your total volume is 162 minus additive volume. Yeah, so 110 ml is your dextrose volume.
So we are done with until step number 7. The dextrose volume, you got the right dextrose volume, 111 ml. So next step is to calculate the dextrose concentration. Now here we are giving 10% dextrose to the patient. So 10% of 162 is 10% of 162, 16.2. So we need to add 16.2 grams of dextrose in the remaining volume. Remaining volume means 75 ml. Sorry, 111 ml. The dextrose volume which we received in step number 7, it is 111 ml. 16.2 grams and 111 ml of fluid.
To make the final concentration 10%. If you want to make it 7.5%, you want to make it 5%, you can, or 12.5%, you can do it. But generally, what is reduced, your adequate glucose for the proteins is around 10%.
Yes. So we have to divide this 16.2 grams of dextrose in 111 ml of fluid. So we'll divide it in dextrose 10% and dextrose 50%. Okay. So I have calculated. So if we take around 98 ml of D10, we'll get 9.8 grams of dextrose. And remaining 13 ml of dextrose 50% if we take, we'll receive 6.5 grams of dextrose from it. 50 grams means 50 grams in 100 ml, 50%. Okay. So the total of 9.8 and 6.5 is around 16.3. We're getting 16.3 grams in 111 ml of fluid.
CNI, the most important part of calculation, and is calorie nitrogen ratio. So the range should be between 150 to 250.
So how do we calculate calorie nitrogen ratio? So we have to calculate first total calorie of how much we are giving. By fat and fat lipid and the carbohydrate. Okay. So fat, we saw that 1 ml contains 2 kilocalories. 1 ml of lipid contains 2 kilocalories. And dextrose we saw 1 ml contains 3.4 kilocalories. Okay. So 1 gram. So then we calculate
15 ml into 2.
So 15 ml is your lipid, so into 2 because 1 ml contains 2 kilocalories. And then from carbohydrate, total 16.2 gram multiplied by 3.4 because 1 gram contains 3.4 kilocalories. So this is 54. So and then we have to calculate nitrogen. So nitrogen for calculation of nitrogen, the formula is total amino acid in gram divided by 6.25.
Remember this total amino acid, not gram per kg. This is the total.
Okay. So gram per kg, amino acid in gram per kg and divided by 6.25. So 6.25 will go up. So 30 plus 55 divided by 3.5 into 6.25. Everybody is getting 151. So this is calorie nitrogen ratio. Our range should be 150 to 250.
In the DNB exams and fellowship exams, we always do a master calorie nitrogen ratio. And believe candidate to such stupid numbers intermediate. But that also always everyone fails. So you must know the formula for CNR, at least for the exam. But when using the software doesn't know also. You don't have to follow. Has to be between 150 to 250. Below 150, range of proteins are very high as compared to the calories. If it's above 250, it's like that. Below 150, it is not allowed. And that's the reason why in the first few days of TPN, you may be very restricted to the amount of protein that you need. So then you all understand. So have the calorie which is 151, which is just okay. So you must, it just ensures then your calorie and protein balance is correct. That is what it means. And if you give too much protein and lesser calories, you can get renal impairment and metabolic acidosis. That's the reason why this kind of transplantation. Okay, now at कौन बनेगा protocol की electric question. What will be the total volume that you will be infusing? You have to write the order of the sheet. What will you order of the sheet now? How many ml will you infuse of this? 162. You made 162. How much are you supposed to give? You will not infuse to 162. आपने ज़्यादा बनाया ना. So the order will say 135 ml over 20 minutes for the nurse, not 160 over 20. Because you made 20% more. Yeah. So ये ध्यान रखना है. You prepare volume जो होता है that is more, but actual volume to be administered should be corrected for 135 because we have made 20% more. So don't forget that last part. And the liquid infusion water volume we came to 17.5 or 15 or we came to has to be given over 24 hours. To divide 15 and then you have 24 and give it by syringe pump. So in the infusion orders on the case paper, it will be 135 ml over 24 hours, not 160. Correct? Those 27 ml you are going to over. And the liquid will be in the syringe. The syringe oxygen थोड़ा ज़्यादा करना पड़ेगा. You have to write that is so many ml per hour. So 17.5 over 24 hours. So order 3. Now this sheet just keep it with you. It's not very difficult at all. But the same calculation now get will do on the software. You put the same values in the software, and that software it will not take more than 5 minutes and give 5-6 minutes for that. So we will be absolutely on time. Can you show it to your laptop? Yeah. The laptop on the stage, you will get up closer. And we will come closer now.
Hello.
Good afternoon, everyone. So we have been discussing about TPN since morning. We discussed various protocols and its importance, especially early optimal nutrition, as sir rightly pointed out. So now I'm going to talk about long-term effect of in nutrition. Actually, it comprises of both total parental nutrition as well as enteral nutrition. So this is kind of a broad topic. We'll see what all long-term effects are there of entire nutrition. So although we are discussing this long-term effect of nutrition for last couple of years, but the discussion is there since long time. We can see that this was famous epidemiological study of Dutch famine in 1944-45, in which they have shown that with the babies who were exposed to famine conditions, they had this increase in incidence of coronary heart disease, obesity, dyslipidemia, and hypertension in later life. Then we all are aware of famous Barker hypothesis. So this was in 1986 when they mentioned that poor nutrition in early life, actually it increases the susceptibility to the effects of the affluent diet in later life. Then we have two more epidemiological studies from Europe. So they have also mentioned that low birth weight is actually a risk factor for various metabolic syndrome in later life. So this discussion is not new. So we'll discuss about the goals of nutrition. We are already talking about goals of total parental nutrition since more strategies and its long-term effect. And as we know that the goals of nutrition is we have to maintain the lean body mass and bone mass. We have to prevent the effects of, we have to prevent bronchopulmonary dysplasia, necrotizing enterocolitis, and sepsis. We have to optimize neurodevelopmental outcome, which is very much important benefit of nutrition, and then optimize adult health. So this fourth part is actually the new concept, which we have started discussing in last few years. So sir was talking about the importance of nutrition and its role in neurodevelopmental outcome. So you can see that nutrition has very much important role in the development of brain. To just compare the constituents of brain between 28 weeks and 38 weeks, we can see that this is hardly any sulci gyri at 28 weeks of gestation. And at 38 weeks, we well-developed sulci and gyri. So our preterm babies are developed at around this age. You can just imagine the condition of brain at that time when we get most of the preterm babies in our NICU. So, and nutrition has a lot of benefits in the development of brain. So this development of brain is like we can compare with building our houses. So what do we do when we build our houses? We first build the infrastructure, and then later we do this wiring thing, the electrical wiring and all. Similarly, the infrastructure of brain develops by around 38 weeks. And after that, in next 2 years of a period, the wiring develops. Wiring means the development of various synapses. And you can see that almost 700 new connections are being developed every second in first 2 years. And nutrition plays a very much important role in the development of this development of brain in this 2 years period. So that is why we are talking about the importance of nutrition in early 2 years of life. We are getting so many preterm babies in our NICU, and the talk is mainly focused on preterm nutrition and the IUGR babies. So they are almost similar. If you compare their adult phenotype between small for gestational age babies and preterm babies, since preterm babies are also developing extrauterine growth restriction. We know that this is very common condition, like it is almost up to 70 to 80%. So this improper growth during early life, it has a lot of implications in adult life. So if you see the neurological system, it is actually, there is a significant decrease in the brain volume and increased risk of neurological disabilities. If you see the cardiovascular and metabolic problems, there is low insulin sensitivity, there is high risk of hypertension, central adiposity, which we are talking about for our last couple of years. So this is, there is risk of increased central adiposity in case of preterm birth as well as SGA babies. And nutrition, especially excess nutrition, has a lot of effect on this central adiposity. So we'll see in the next few slides. Then there is some increased arterial stiffness, which is the responsible factor for hypertension in later life. If you see the bone health, there is a significant lower bone mineral density in the case of preterm babies. In case of adults who are born preterm. So we'll focus on these 4 important long-term effects of nutrition. We'll talk about growth. So since morning we're talking about growth. Then neurocognition, which is most important long-term outcome of nutrition, bone health, and metabolic syndrome. So if you see various guidelines, the recommended dose of protein is almost around 3.5 gram per kg per day in early life. And if you see the energy, this is around 110 to 135 kilocalorie per kg per day. We have to focus upon this protein energy ratio, because this is going to have too much implication on the various metabolic syndrome and the neurodevelopmental outcome in later life. So we have to maintain at around 2.5 gram of protein per 100 kilocalorie, roughly around 2.5 gram of protein. So how do we reach this ratio? There are various strategies available to reach that magic number of this 2.5 gram of protein per 100 kilocalorie of energy. So like unfortified preterm formula, then donor milk, high protein formula. So we can see that this preterm formula actually, this is only reaching that magic number of 3.5 gram per kg per day of protein in initial life. And I have not mentioned here the fortified breast milk, which is also almost reaching up to that magic number of 3.5 gram per kg of per day of protein in early life. So the discussion about a neurodevelopmental outcome of nutrition. This is very much famous study by Rankins et al. Way back in 2006. They have mentioned that if there is increased weight gain, that is in gram per kg per day, like from 12 gram per kg per day to 21 gram per kg per day, as the weight gain is increasing, we can see that the incidence of cerebral palsy, incidence of mental developmental index less than 70, incidence of psychomotor developmental index less than 70, as well as neurodevelopmental outcome. All these parameters are actually improving. So there is less risk of these problems if at 18 to 22 months of age, as the weight gain in gram per kg per day increases from 12 gram per kg per day to 20 gram per kg per day. And in the same study, they have mentioned the effect on the growth also. So at 18 to 22 months of age, they have reported that weight less than 10th percentile as well as length less than 10th percentile, both were actually good if the weight gain is increasing from 12 to 20 gram per kg per day. So from this study, we can say that we have got that magic number of 15 to 20 gram per kg per day of growth in the early life. So they have compared between two groups in which the weight gain was 12 gram per kg per day versus 21 gram per kg per day. And you can see that cerebral palsy, mental developmental index less than 70, as well as neurodevelopmental impairment, all are actually, there is less risk in the larger weight gain group. So it has other benefits also. So we talked about 3.5 gram per kg per day of protein. So they have compared between high protein formula versus standard protein formula. Standard protein formula is normal term formula, which has lesser protein. So they have reported that there is higher motor score as well as social maturity in case of high protein formula group. And the risk of IQ less than 85 is also less in high protein formula group. Okay. So then we talked about catch-up growth. So we know that this catch-up growth term has come from nephrotic syndrome children basically. So after an illness of nephrotic syndrome, these children actually grow and then they compensate for the loss of nutrition. So this catch-up growth has come from that population, and we have started using this one for our preterm babies as well as LBW babies. We know that this catch-up growth happens between 6 months to 3 years of age, depends upon the babies. So there is a lot of discussion about this catch-up growth, whether this is beneficial or not. So we'll see in few slides. So if you start nutrient-enriched formula, definitely there is improvement in weight gain, linear growth, as well as various later outcomes. So catch-up growth has definite advantage in the growth as well as neurodevelopmental outcome in later life. So it has benefits over the iron stores also. And early catch-up, if it is there before 6 months of age, it has been shown that it actually increases the linear growth as well as other neurodevelopmental outcomes in later life. So catch-up growth is beneficial in the growth as well as neurodevelopmental outcome. But is catch-up growth beneficial always? So that is the point of discussion. So what is the effect of catch-up growth on neurodevelopmental outcome? Let us see. So few studies have shown that if catch-up growth is there, it has benefit over better mental and motor development in later life. It improves long-term neurodevelopmental outcome. And it has been shown that if there is absence of catch-up growth, then there will be lesser intellectual as well as psychological performance, especially in SGA babies. So catch-up growth definitely has been beneficial for neurodevelopmental outcome as well as growth. This recent study in EpiPA's cohort, they have shown that if there is poor postnatal growth, then that increases the chances of cerebral palsy at 18 to 22 months of age. So, but now the point is weight gain we are talking about. So what does it increase? Does it increase only fat, or are we concerned about improvement in lean body mass? So there is the discussion. So in this study, they have shown that if you give breastfeeding, so we can see that in case of breastfed baby, in later infancy, we can see that the amount of fat deposition is very less in case of breastfed babies as compared to formula-fed babies. So then let us talk about Barker hypothesis. So there are various factors which lead to development of poor fetal growth as well as early growth failure in infancy. So it could be because of maternal factors, fetal factors, placental factors, or other factors. And it actually causes changes in the epigenetic. So because of this epigenetic changes, there is alteration in the gene expression, and that leads to various metabolic syndrome. Okay, so this is this epigenetic changes which is responsible for all the long-term effect, especially metabolic syndrome in case of LBW babies. So this epigenetic changes have long-term effect on almost all the systems. So you can see that it has effect on the bone health. It can lead to osteoporosis. It can lead to immune dysfunction, a long-term effect, metabolic syndrome, type 2 diabetes, hypertension, dyslipidemia, obesity, a risk of cancer, a decreased lifespan. So it actually affects almost all the systems. So there is new concept of development developmental origin of health and disease. So this is based on Barker hypothesis only. So what happens in case of poor antenatal, because of poor antenatal environmental condition, there is reduced fetal growth, and that leads to epigenetic changes. And if you provide excessive nutrition after that, then that will lead to this developmental origin of health and diseases. So it has been, this is a recent study, Project Viva, in which they have reported that if there is rapid increase in weight for length, then there is high chance of risk of obesity at 3 years of age. And same cohort when was followed at around 10 years of age, they found that there is risk of high systolic blood pressure if there is rapid increase in the weight for length. So in this study, they have compared between breast milk or term formula, which is non-enriched, that means lesser protein, and preterm formula, which contains more protein. So they have reported that there is less insulin resistance, lower blood pressure, lower LDL by HDL ratio, and higher leptin by fat mass ratio. So what are the long-term complications of this excess nutrition, what we call in case of LBW babies? So it can lead to obesity, diabetes, type 2 diabetes, hypertension, and cardiovascular diseases. Catch-up growth has implication over development of hypertension in later life. In various studies have shown that if there is SGA infant, and if this SGA infant crosses 2 weight percentiles, then there is higher risk of development of hypertension at 7 years or later life. So basically, we have to balance between this development, because this is definitely beneficial in neurodevelopmental outcome, and between various metabolic consequences. So the conventional nutrition is will lead to growth restriction. It will definitely have neurodevelopmental impairment, and it will lead to metabolic bone problem. And if you give aggressive nutrition, that means optimal nutrition, then there will be better postnatal growth. It will cause adiposity, and there is a risk of cardiovascular disease. So basically, we have to balance between this conventional nutrition and aggressive nutrition. So do we have any solution? So this is as per WHO. We have seen that mother's own breast milk has been shown to be best formula, best milk for the babies. And if you increase the duration of breastfeeding, there is improvement in intelligence. If you see that the IQ level, as the duration of breastfeeding increases from less than 1 month to more than 9 months, we can see that the IQ level is increasing significantly. So breastfeeding has definite advantage over the neurodevelopmental outcome, especially intelligence. There is dose response effect also. So like if you increase even by just 10 ml per kg of mother's own breast milk, it will lead to increase of the MDI by almost 0.59 points, belly PDI almost 0.56 points, and behavioral index also by 0.99 points. So there is dose response effect also. It is not like if mother is getting some lesser milk output, we should not give that. So even whatever we are getting, if we give, that is actually beneficial. And it has definite implication over risk of obesity. Like in this study, you can see that if the breastfeeding is provided for more than 9 months, it actually reduces the risk of obesity by almost 30%. There is plateau effect after 9 months of breastfeeding, but there is definite advantage on the risk of obesity. And each month of breastfeeding was found to be associated with that 4% increase, 4% decrease in the risk of obesity. Okay. So then we talked about optimal growth. So we have to provide growth of 15 to 20 gram per kg per day during early infancy. And we have to avoid rapid catch-up growth and adiposity, and especially central adiposity. So in this recent study, here you can see that in early life, we can provide, so the upper panel is for protein in gram per kg per day, and lower panel is for energy. So you can see that in initial weeks of life, the amount of protein required is more. It is almost close to 4 gram per kg per day, which we have to reduce to almost 2.5 gram per kg per day in later life. Similarly for energy also. So the requirement is at around 135 kilocalorie per kg per day in initial life, initial weeks of life. And then we have to decrease the requirement of calorie to almost 100 kilocalorie per kg per day in later weeks of life. And we have to maintain this protein calorie ratio to avoid central adiposity. So what should be the ideal practice? We have to provide early aggressive nutrition. I'll refrain from this word aggressive. We should tell early optimal nutrition. Mother's own milk is best, as we have seen that there is even dose response effect on the risk of various metabolic consequences in later life. Early fortification. Nowadays, we are talking about early fortification even at 50 to 80 ml per kg per day of enteral feeds, which definitely provides that magic number of 3.5 gram per kg per day of protein. Always maintain this protein calorie ratio, whether you are providing TPN or enteral feeds, you have to maintain this protein calorie ratio. We have to maintain optimal provision of vitamin D, calcium, and phosphorus to maintain bone health and iron. Growth monitoring is utmost important. We have to use growth charts and we have to see that there should not be lesser growth as well as there should not be overgrowth. Like we have to avoid central adiposity. So our target should be prevention of EUGR, which is very much common in our setting. It is almost as common as almost 70 to 80%. And we have to avoid central adiposity. So provide best nutrition and improve future outcome. Government of India has launched this program, RBSK, Rashtriya Bal Swasthya Karyakram, in which they focus upon the journey of first 1,000 days. That includes the period of conception as well as first 2 years. So the nutrition is the main part of this first 1,000 days journey, and this actually builds the foundation of future. Thank you.
All the aspects are well covered, and I think from the practical point of view, nobody knows what is right catch-up growth. We are saying excessive catch-up growth, less catch. Nobody knows what is right. So what is the growth that gives you the right neurodevelopment without metabolic syndrome? That exact point nobody knows. But generally what people feel is that initially it doesn't matter, but later on prevent micronutrient deficiencies, and as far as possible don't cross 50th centile for your age. And preterms who grow up have to be put in a very rigorous physical activity program once they become toddlers, and prevent obesity in them, and 50th centile is generally what is accepted. Breast milk, I think, phenomenal data to favor, and breast milk is the only intervention that improves neurocognition and prevents metabolic syndrome. That's the only thing really that people know for sure. Other things we really don't know. So how much is the genetic role, epigenetic role, how much is early growth? Nobody knows the contribution of each of those factors. So excellent talk. We'll move on. I think Veera, your talk. Only TPN we've been talking. So I think Veera is going to tell us a few new things about enteral nutrition and update on what's new.
Thank you, sir. My talk is much simpler. I'm not sure why the slides are coming like this. Sorry. So the talk is on enteral feeding in preterm newborns. Do you have the So a brief overview of the talk. First, we'll look at the different enteral feeding regimens that have been evaluated in various randomized control trials. Then we'll go on to fortification of breast milk, what all strategies are presently advocated. We have to discuss a bit on the most important aspect, using mother's own milk and exclusive breastfeeding. What are the complementary strategies to establish successful enteral feeding in preterm babies? We'll look at some special scenarios where how to go about enteral feeding, and finally some take-home points. So there is a general paucity of consensus as to what is an appropriate feeding strategy, especially in very and extreme preterm babies. So there is this physician's fear of necrotizing enterocolitis with early aggressive feeding compared to the possibility of acquiring late onset sepsis when you go slow on enteral feeding. The critical aspects as practicing neonatologists that we want answers for are time of initiation, when should we initiate enteral feeding, when should we advance from trophic feeds to nutritive feeding, by what volume should we advance. These are the things that as practically as neonatologists we are concerned about. These are largely unanswered. Establishing enteral feeding, there is no single silver bullet strategy for that. There are so many things that can influence whether a baby will tolerate the regimen that you are using in your unit or not. Whether the baby has received antenatal corticosteroids or not is an important aspect. Delayed cord clamping, the previous reviews had showed that it decreases the risk of necrotizing enterocolitis, whereas the most recent reviews published in pediatrics have shown that it does not influence the risk of necrotizing enterocolitis. Of course, the gestational age of the baby, whether the baby is growth retarded or not, how sick is the baby, the type of milk that you are using, what is the probiotic policy in your unit, and the broad spectrum antibiotic usage. All these factors will affect your enteral feeding policy in your unit. So multiple Cochrane reviews are evaluated the different aspects of preterm enteral feeding, and they have come to different conclusions. But what, as I discussed before, what matters for us is, for a particular baby, when should I start, advance, and by what volume I should advance. So these are the 4 important questions that we always face. So traditional pairwise meta-analysis is what the Cochrane utilizes, and that is what even the ILCOR utilizes. They are very resistant to doing different type of meta-analysis, except for individualized patient data meta-analysis. So myself, including Dr. Pratik, we had tried to address these questions by a network meta-analysis by comparing different enteral feeding regimens. And we tried to even derive evidence when direct head-to-head evidence was not available from randomized controlled trials. That is the main advantage of using a network meta-analysis. I don't want to go in detail into a network meta-analysis, but this is a paper that we had published in Annals of Nutrition and Metabolism. This paper was rejected by other journals with higher impact factors. Even this is a journal with a decent impact factor, because the main comments from the editorial board was that it is difficult to understand the paper. As a reader, they won't be able to derive any reasonable conclusions. So that was the main reason why pediatrics rejected this paper, though the reviewers suggested to accept the paper for review. But finally, somehow we got it into Annals of Nutrition. So these were the different strategies that we had evaluated, almost 16 feeding strategies that we tried to address. The sad part is, not able to point it out. Sad part is the lines connecting the interventions. You can see there are hardly 1 or 2 studies comparing these strategies. So the final certainty of evidence is going to be low, whatever meta-analysis that you use to analyze this particular subject. So what we found out it's not a very popular thing. It will not be a popular thing here in India. In a sick preterm neonate, of course, early initiation, all of them will agree. When it comes to advancement from trophic feeds to nutritive feeds, when you advance between 3 to 7 days, and at a moderate volume of around 20 to 30 ml per kg per day, it decreases the risk of mortality or NEC. This is our final conclusion of the paper. but the certainty of evidence behind these findings were low to very low. So this is what we derived from our analysis. I just want to know whether how many of you agree with this thing, especially the second part, because many of us start on day 1 and start advancing on day 2. Sir, your take on this?
I think we start on day 1 and we start grading up immediately on day 2, but we are usually most of our babies are full feeds by day 7. So we belong to the second group.
So it's quite controversial. We, even though many of us, including Pratik, we are trained from an institute where even less than 1,000 grammars are put on full feeds from day 1. We did not agree with the findings, but whatever were the findings, we had to report it without any bias. The outcome was NEC or mortality. So if I mean, they are competing outcomes, so we did not analyze them separately. Suppose it's a composite outcome. So otherwise it will be difficult to analyze. Some babies might die before even developing NEC. So what about IUGA babies with abnormal Dopplers? Only 6 studies were there, all from low and middle income countries, and none of the feeding strategies seems to affect the outcome of mortality or NEC. So even in, I mean, all these 6 studies, I'm not showing the forest plot. Most of them were from India. What about early total enteral feeding? That is, from day 1, the baby is on full feeds. There are 6 studies, all from India again. So whenever there is a discussion about research from India, the most important PCOS, the study, that are analyzed in a systematic review, you will have at least 50% of studies from India, including on feeding, hypothermia, and other aspects. So the certainty of evidence was again very low for early total enteral feeding. The Feed 1 trial is, as of now, ongoing in UK. They are planning to recruit around 3,000 babies of gestational age of more than 30 weeks. And they will be on full feeds versus MEN plus total parenteral nutrition. So I'll just show the most recent Cochrane review on early total enteral feeding by Walsh et al. So the risk of NEC is almost the same when a baby is put on early total enteral feeding compared to a baby who is started on minimal enteral feeding and IV fluid or TPN. Most of these babies were more than 1,000 grams and stable as defined by the authors. There were no objective criteria to define what stable meant. Now, compared to the feed volume, till how much volume we can go. So this is the latest Cochrane review by our good friend Abhiram Lata and Tanigai. Both of them collaborate with us in many of the reviews. So high feeding was defined by them as more than 180 ml per kg per day, and standard volume was less than 180 ml per kg per day. And there were 2 studies. One had evaluated 200 ml per kg per day, and the other one has evaluated around 140 to 160 ml per kg per day. What they found out was that the mean difference in weight gain was higher. I am not sure whether it is clinically significant or not, but statistically it was significant. It was around 2.6 gram per kg per day in the high volume group. And the risk of NEC was almost the same. This is all about feeding regimens. I'm not sure whether I was able to convey to you a regimen that is most safe for your babies, but this is what the evidence is as of now. Now coming to fortification, fortification is advised in all babies who are less than 1,800 grams and or who are less than 34 weeks. When to start fortification, traditionally we start at 90 to 100 ml per kg, but with accruing evidence, we are now presently starting at 50 to 80 ml per kg. Bovine HMF is what we are using, and there is good certainty of evidence for that. What about human milk-based fortifiers? They are recently available in the market. They are very costly. There is an issue with safety. We don't know how efficacious they are. Ethically, to get a small amount of to get even a single sachet, they have to utilize lots of mother's milk. So in a country such as that of ours, whether we are ethically right in using human milk-based fortifiers is something that we can have a debate on. Standard fortification is what we use. For every 25 ml of milk, we add 1 gram of HMF, but there are so many shortfalls with such an approach. The most important reason is the manufacturers take it for granted that human milk contains around 1.6 gram per deciliter of protein. But that is not the truth. In the first 2 weeks, it might be, but beyond 2 weeks of age, the protein content comes down. So if you are using standard fortification, we might not actually reach the target as suggested by different advisory bodies or Professor Ziegler. So individualized fortification is presently being advocated. There are 2 ways of doing it. One is a practical way, which is the adjusted fortification, and the other one is the theoretical way of targeted fortification. So we'll discuss about adjusted fortification in the coming slides. And what about post-discharge fortification? Suppose a baby who is born at 28 weeks, you are discharging at say 34 weeks. Are you going to put the baby on fortifier in a country such as that of ours, or would you be trying to establish exclusive breastfeeding? So that is something that has got little evidence, but most of the advisory bodies suggest fortification till at least 40 weeks, and if possible, up to 52 weeks as well. Sir, do you disagree with any of these comments? And particularly these human milk based fortifiers, what do you think is your view, sir?
There are babies who don't tolerate bovine fortifier, and babies vomit and have feed intolerance. So in those babies, we use human milk-based fortifier. And very small babies, say 780 grams, 600 grams, we start fortifying them and we give them exclusive human milk-based diet. So we use only human milk-based fortifier, and no exposure to any foreign protein. And once the baby crosses 1 kilo, 1.2 kilos, then we switch to the bovine. So we do use it, but in between we had a problem when the sachets were found to be contaminated with bacteria. The babies did worsen. So we warned the company severely, and there is a little bit of problem with quality. The company always denies, but we have grown bugs from the human milk-based fortifier, which we have given the reports to them, but they say our lab doesn't show that, and the baby did worsen after that. So we should be careful that maybe the standards are not as good as we think.
So I agree with sir. You may use it as a rescue measure rather than the human milk-based fortifier, but the aspect of safety is what even the Western advisory bodies stress upon. There is a risk of bacterial contamination, and these are all not FDA or FDA equivalent approved. They are regarded as grossly safe for use. It's like FSSA or something. Some body is there. They are operated by them, not the actual standard regulatory body. In India, I think it is DGCI. So in US, sir, prolactin US FDA, not approved. So
your experience was good with human milk fortifiers. So as sir rightly pointed out, Prolacta is the US commercial dollar bill company. Neolacta is part this year. In Neocon, it is not appropriate to discuss about companies, but overall human milk based fortification is possible in India, and there are different views on that. So what do you mean by standard?
what do you mean by adjusted fortification, which comes under individualized fortification? Once you start fortifying milk, when you reach 50 to 80 ml per kg per day of feeds, you start monitoring the blood urea nitrogen values. The target value that you want is somewhere between 10 to 16 milligram per deciliter. This is done twice weekly as per this recommendation. If it is less than 10, then you increase fortification to the next level. So what do they increase? They add special protein powders. I am not sure whether they are available in India or not. What I do is I increase the concentration of HMO. So the increase, but you might be giving additional amounts of other minerals and vitamins than the standard RDA recommended allowances. So if you have a BUN of less than 10, you go up by 1, you increase the content by 0.4 gram per 100 ml of milk. Then you keep on monitoring the BUN, you can go to a maximum of 1.2 gram per 100 ml of additional protein in the milk. This is apart from the standardized fortification that you will be doing. So this is an individualized, adjusted fortification strategy that is practiced in many Western countries. Now, this is an important paper that I wanted to talk about, which was recently published in JAMA Pediatrics by the AIMS group. So they have compared fortification of human milk with human milk fortifier versus preterm formula. You know that cost constraint is an important aspect with fortifier. And what they found out was that the mean weight gain in the preterm group was comparable compared to fortifiers. And the incidence of feed intolerance was significantly lower in the preterm formula group. That is where human milk was fortified with preterm formula powder. So their conclusion was that preterm formula powder might be a better alternative compared to dedicated bovine human milk fortifiers. So this is an important paper that was recently published.
And if you do this, the vitamin D, calcium and phosphorus is very low. So if you do that, you might do well with the protein.
You have to get extra calcium, phosphorus, and vitamin D has to be given when you do that. So it's not the best thing to do.
The cost issue is the main concern.
What is the function cost around the 800 rupees?
Yes.
And the risk of contamination using the same thing in street clearly open on packet. So if I am not available, that is okay. Yeah, then yeah, now I think we are not trying this now, not now.
Such kind of papers, people tend to do some wrong practices, right? Yes. So this might be relevant for African countries, maybe, not for India. We are highly advanced.
I have read this article, but I don't.
So as sir rightly pointed out, the group, the preterm formula group received additional calcium, vitamin D.
The cost of that has to be added.
Added, yes, yes.
And people compare formula being expensive. Then the people think cow's milk is also. Cow's milk is not free. You calculate cow's milk also has a cost. So when you compare two things, you must compare both the costs completely. And if you check formula and cow's milk, actually head to head, difference is very less. It comes to 300 rupees a month or something.
And there is always a risk that this formula is used for. And the risk that the mother uses that to feed the baby. Yes. Because this was from an Indian group, I thought I'll just point out to this paper.
I don't think any of us should
do it. Yes.
Regarding HMS, the only efficacy data is for short term.
Yes.
Only land duration itself.
Yes.
There's no data for long
term.
There is a group specific of HMS. Any HMS.
What happens is you show growth in head circumference. You definitely want to translate to long term. Secondly, when they talk about long term for this, they only 18 months. They are long term 18 months. They are not studying long term. I personally think that 18 months is not completely enough because people are studying till adulthood. 5 years. And secondly, for improvement in hair circumference, better than. And there are so many other factors that affect your IQ. That again, you can't say by 45 because of 45 IQ.
But there is a group which believes that you go on increasing the volume, you still meet the protein requirement. You don't need extra 200 grams.
But that is difficult because we have seen that on 200 ml per kg, that's the maximum volume that we give. There is still a protein shortfall. And secondly, when we do milk analysis in our unit, sometimes the mother's milk protein as low as 0.6. So
we have to check mother's milk protein. If you have a large volume of milk, but very low protein. So that is not the reason why when babies like we had a preterm moment of idling feeding, and we calculated that the fellow was drinking more than 300 ml per day. It was an idling. Of course, the mother was still complaining to come out 300 ml each, but that showed up. We stop at 200 because we cannot more than 200. But idling the fellow should be 15, 16 per happy. So unless somebody is taking real good volumes and unless the milk protein of the mother is good, you can't guarantee that the baby will have enough protein. 300 ml 3 times. Yeah. But all babies have. So there is a study that was included in that Abhinav Lata's Cochrane review where they have compared, I think, 320 or something versus 200. So there are studies on that as well. I'm just interested in asking, sir, you have a milk analyzer. What are the
can we practically do targeted fortification in our NICU?
Just about targeted fortification is not possible in our country because you don't have separate proteins, separate carbohydrates, separate fats. And even in the West, a lot of people have stopped using targeted fortification because it's a time consuming thing. Every time you have to analyze the meat sample, each and every day there is a difference. Every day you have to be some change in the formulation. So even those people they have stopped those targeted fortification. And they very more in standard now other than adjustable now. And the equipments are all for dairy industries. I don't think they are calibrated for human milk. Yes. In my understanding. So this is I intentionally put this topic as in the last. So mothers own milk. There are lots of discussion about donor milk, milk banks, comprehensive lactation management centers. But remember the advantages of mother's own milk, as pointed out previously in the talk, is something that you might not be able to visualize, but that is something that will do a lot of good to the baby. The risk of NEC increases if you use formula milk to the tune of almost 87%. Now, this is a paper frequently quoted Lancet series paper published in 2010. Again,
the authors being Jiva Shankar. So, early initiation of breastfeeding, what sir was talking in the introduction, around 90%, more than 95% of the mothers have started on, babies have started on exclusive breastfeeding within the first hour of life. The actual rate for a low and middle income country is around 30%. You can see that red line. And continuing exclusive breastfeeding from there till 6 months is only 40%. But when you compare with other income countries, the high income countries, the low income countries seem to do well, at least for this aspect, relatively. But we need to really look at our things, and maybe programs like Mother's Absolute Affection and all might have increased this really concerning low rates of exclusive breastfeeding within the first hour of birth and continuing exclusive breastfeeding in the first 6 months of life. Out of all the LMICs, Sri Lanka is known to be one of the countries where exclusive breastfeeding rates are quite good. So, breastfeeding benefits for the infant. This is for all the postgraduates. You can read that wonderful paper by Jiva Shankar. It decreases the risk of mortality by almost 88%. Diarrhea by 63%, hospital admissions due to severe diarrhea and pneumonia by 60 to 70%, ear infections by 33%, allergy by 21%, and future adult asthma, childhood asthma by 10%. Long term, it decreases the risk of obesity as well as diabetes. It increases the IQ by more than 7 points. So there are different comparisons, exclusive breastfeeding versus total formula, partial feeding versus total formula. So I just given you a gist of that results published in that article, but please go and read those two series published in Lancet. So infant mortality. And this is for exclusive feeding versus no feeding at all. And I don't think there will be any more RCTs coming on this topic because it's a standard of care. And mother's benefits, I'm not going into that, but the risk of breast and ovarian cancer decreases, and there is a dose response gradient as well. So previously they used to tell breastfeeding till 2 years. Now it is at least 2 years. So continue beyond 2 years. That is what WHO recommends. And there was a wonderful debate in Western Neocon between Madam and Amit Upadhyay. He's a strong proponent of exclusive breastfeeding. So exclusive breastfeeding, if you scale it up from the present rates that were, based on the paper published in 2010, you can prevent 8,23 deaths in children who are younger than 5 years. And you can also prevent 20,000 annual deaths of mothers from breast cancer. So the other complementary strategies that I discussed about previously that will help you to get a preterm baby into full enteral feeds earlier include restricting the use of augmentin in the antenatal mother. This is based on I forgot the study's name, Oracle. 1 and 2. I think it's 2.
So you restrict augmentin, the risk of NEC decreases. Use of antenatal steroids. Delayed cord clamping is now.
So, you should do delayed cord clamping, but the effect of delayed cord clamping on NEC is unclear as of now. Use of mother's own milk in your unit. Probiotics, it's a controversial topic, but yes, there was a viewpoint published in JAMA Pediatrics recently by Gautam Suresh and Abdul Razak, where they have argued against doing further randomized control trials on probiotics. So probiotics does help. Which one and all is a big debate. So I think we might be having it in the next sessions tomorrow. Empirical use of antibiotics is something that is quite dangerous when it comes to the outcome of NEC. You restrict it to less than 48 hours. The moment you get a 48-hour culture that is sterile and you're seeing a baby who is not looking infected, please stop antibiotics. The more you use, the odds of NEC, fungal sepsis, and death increases. And that also has got a dose response gradient. Use a standardized feeding regimen in your protocol. Your feeding regimen should not be based on the consultant who is coming on rounds. So use of standardized feeding regimens decreases the risk of NEC by almost 75%, as shown by Sanjay Patola in his systematic review. Avoid using H2 blockers and PPAs. These are very popular with pediatric surgeons and many pediatricians as well. Please avoid it in NICUs. Contraindications for cautious feeding in babies with severe perinatal asphyxia, IUGR with abnormal antenatal Doppler, where we don't have enough evidence. When you have a surgical abdomen, baby is hemodynamically unstable, requiring significant inotrope therapy, which is usually defined as dopamine of more than 10 microgram per kg per minute. HSPDA during feeding during HSPDA is something that is being debated. Similarly, transfusion during whether what to do while baby is planned for transfusion. The usual practice now is to keep the baby nil by mouth 4 hours pre-transfusion, during transfusion, and 4 hours post-transfusion. This is what is practiced in UK units. We don't do it. So, yes, so there is a wonderful article in Neo Reviews where they have compared different strategies of blood transfusion along with NEC, and this seems to have some evidence for that. So I'm not sure what is the policy in other units. Do you give feeds during transfusion, sir? 4 hours. What about St. John's? Continue. Indira Gandhi.
So Bangalore seems to have a uniform standardized transfusion policy. So coming to
Absent of reverse and diastolic flow, this is the ADAPT trial. Actually, one of the authors of this trial was an author in our network meta-analysis, but his contribution did not satisfy the journal requirements. So we couldn't put him as an author. So what the strategy they had used is they have initiated early. Mean duration of initiation was around the third day. They advanced early, like how sir said. The day they started, the next day they started advancing at a volume of around 20 ml per kg per day. And always do clinically examine the abdomen and then take a call on how to feed these babies. HSPDA, so there is no evidence, the evidence from two retrospective studies and one randomized control trial shows that you can continue feeding during the time period when the baby is being treated for a hemodynamically significant PDA, and the advancement can also be continued. You need not keep the baby, put the baby back on MEN, or you need not stop incrementing the feeds. But there is no evidence for the same with paracetamol. Hopefully, if it is safe with indomethacin and ibuprofen, it should be safe with paracetamol as well. The take-home points are use of mother's own milk and exclusive breastfeeding. The regimen in sick neonates, what we found out was what we discussed earlier. More than 30 weeks of gestation. Early total enteral feeding is a potential regimen. We might have to wait till the feed-1 trial, which is adequately powered with a robust design, is published. You can target a high volume of around 200 ml per kg per day. Adjusted fortifications, sir does not agree with that because we don't have individual components. But if a baby is not gaining weight on standardized fortification, then what to be done? We need to discuss. Complementary strategies is what is frequently overlooked. Use of antenatal corticosteroids, avoidance of augmentin, use of human milk, probiotics, antibiotic stewardship, avoid certain drugs, and follow a standardized feeding protocol in your unit. Thank you.
Absolutely excellent. Everything well covered, and some of your own good data and research also shown the excellent topic. So now we are going to get rid of the panel discussion at the end because we had a lot of interaction. So we'll save 1 hour clearly at the end. We have 2 talks now and 2 small workstations. We should be able to finish by 5. Okay, and we will try to squeeze in a tea break in between. So is there a tea break in the middle? So we'll have a break in between so that they will finish up the 2 talks and 2 workstations by 5 o'clock. So now I introduced Amrita Desai, who I told you in the morning, nutritionist with special interest in lactation management. People have qualification degrees, but I think she's exceptional in her work. A lot of times when I hear her talk on breastfeeding and neonates, they have completely no idea what all is there with them. And there's technology that will show. Every time I hear something new. And different kinds of techniques now and different kinds of coming in the market. And we as pediatricians are not so much aware as to what changes occur in their field. So let us see what she has to tell us.
Hello, everyone. Good afternoon. Thank you for being here in these many numbers. I'm very happy to present a topic which is very close to my heart. So we'll be speaking about newer aids in lactation, and I'm glad I'm doing it to a room where most of you are men and generally give up when a mother says she has issues with breastfeeding. So this will really help you to provide some answers. Why do you think we need to have aids in lactation? These are the multiple reasons why. You need to ensure that the mother can establish, maintain, and enhance her milk supply. People like me do a lot of troubleshooting of lactation issues. We need to give the mother relief from painful breastfeeding. Telling a mother to continue with breastfeeding when it is excruciatingly painful is just not right. Finding a way which is efficient, comfortable, and less time consuming, especially if the patient is a mother who has just given birth to an 800 grammer, the one we have been discussing since morning, and feeding babies with poor feeding ability. For all these things, just telling the mother, oh, breastfeed, that's it. That's not the case. You have to give her answers to the problems that she's facing. The reason we need to establish, maintain, and enhance a milk supply is all these things. The way to go about it is all these things. So stimulation to the breast is essentially a supply and demand cycle. What we need to know is we do go out of the endocrine control. All of the time it's not under the oxytocin or the prolactin reflex. So after a couple of days, it does move on to the complete supply and demand cycle. So we have to ensure that the mother is either properly breastfeeding, where the baby is draining the breast completely, or she is either massaging and expressing the milk well, squeezing the milk out, or
rest of the care planning time is
what's
completely
very, very important
the supporting areas are not important.
the
Only the
first
perinatal
72
areas are important.
the first 72 hours after birth, when she's dealing with colostrum, the transitional milk from day 3 to day 5, and beyond that from 1 week to 10 days when she's just establishing the mature milk supply. So she has to begin expressing within the first 6 to 12 hours. If she's able to pump or manually express, the numbers are somewhere between 8 to 12 times per day, 10 to 15 minutes per session. And what's very important is the last line. The frequency is way more important than duration. You have to tell a mother that marathon pumping sessions do not help. She can't sit with a breast pump for 25, 30 minutes at a stretch. She can do it for 10 minutes each breast, take a break, do 5 minutes each breast, take a break, come back and do a 5-minute session again. So the many more times she stimulates, the better milk output we'll see. This is something that a lot of pediatricians do not know. FIL is known as a feedback inhibitor of lactation. It is a protein component. This is present in the mother's milk supply. The more engorged she is, the more full she is, the less she is pumping, this is going to keep on increasing in her milk. And this protein factor sends a signal to the brain, telling the brain that she need not produce any more milk. So if I see a mother who's engorged today and she's not done anything about it in the next 24 hours, the next day when I come back and see her, the supply has taken a hit. So feedback inhibitor of lactation is important. You should be aware about it. And there shouldn't be any unrelieved engorgement in the mother's breast. The manual technique of milk expression is fair enough. A lot of parents know this. But when you're dealing with an NICU mother, then you need to ensure that she knows about breast pumps as well. What's important is you tell her which pump to use depending on her requirement of using a breast pump. So what could be the indication? It could be prematurity, like we've been discussing since morning. It could be engorgement. It could be an anatomical issue of the breast, like flat or inverted nipples. Something as simple as a breast refusal because the mother has been incorrectly guided to bottle feed. A cleft lip or a cleft palate. A severe tongue tie in certain situations. Moms going back to work, which is currently the norm since they even go back at around 2 months. And mother being ill or hospitalized and being away for the baby. These are not breast pumps. This is a part of my every newer aids session. These are very easily available. They are priced at 30 to 90 rupees, and any local pharmacy that you have will have this and will sell it as a breast pump. But these are not breast pumps. They offer no relief. And the pink or the red colored horn pump side that you see, that is actually made of plain rubber. And when the mother tries to express the milk, it goes way down that reservoir and she pours out of it again. It's not clean. You are inviting infections if you're asking mothers to use this. So these are not breast pumps and these are not supposed to be used. When we speak about breast pumps, and especially if you're talking about electric breast pumps, you need to look at different suction ranges. You need to find out what suction pressure is comfortable for the mother. You need to see whether she'll be using unilateral or bilateral pumping, which simplistically means whether she'll be pumping one breast or whether she'll be pumping both the breasts in one session. For mothers who give birth to ELBWs and LBWs, it's recommended that they simultaneously pump both the breasts because she'll have more output of milk. Single or double phase pumping means that single pumping will only have an expression mode, whereas a double phase pumping has a stimulation cycle as well as an expression cycle, which in turn mimics what a term baby would do at the breast. It would stimulate the milk to flow and then the milk would be expressed out. Customable flange sizes, durability and portability is very important because one size does not fit all where breast pumps are concerned. So you have to ensure that the mother's using the right pump. The comfort, availability, cost, and ease of cleaning is equally important. And at the end of all this, whichever pump she is deciding to use, she needs to understand how to use it. You give her the best pump in the market, but she doesn't know how to use it, it's not of any use. So there are three basic kinds of breast pumps: the manually operated ones, the battery operated or the small semi-electric pumps, and the hospital grade breast pumps. So these are all the manual breast pumps. These should be ideally given to mothers who will be pumping once in a blue moon. Someone who's just stepping out for maybe a social evening, someone who's going to be away from the baby for 2 hours. You shouldn't be recommending any of these breast pumps to a mother who needs to be pumping 8 to 10 times in 24 hours. Battery operated breast pumps, price ranges are somewhere between 3.5 to 8 to 10,000. And these are all single use pumps. These are again not meant for mothers to share amongst themselves. That's very important. When we speak of hospitals and NICUs and cost cutting practices, these are commonly what are purchased and mothers end up sharing the same pumps. So please don't do that. You can instead go in for hospital grade pumps. So these are the hospital grade pumps. These are very expensive. The Medulla Symphony, the yellow one in the corner there, is currently priced at 1,50,000. The Ardo Carum, which is the white and green in the lower end, is also 1,20,000. So these are fairly expensive. These are not told to mothers for self-purchase. These are available at the hospitals. At Cloud9, we have hospital-grade breast pumps in our NICUs on each of our maternity floors. And the bottle and the flange, the tubing, that's known as a kit or a consumable kit. These are called for mothers separately or indented in their names. So the mother has her own set. She comes, she uses the pump, collects the milk and goes away. So hospital-grade pumps are much better because they have the two-phase pumping of stimulation and expression. It helps with a faster let down. It can help with bilateral pumping, and it's easier for the mother to maintain her milk supply. So generally, my policy for an NICU mom is that she takes a hospital-grade breast pump on rent, establishes her breast milk supply well, and post that switches to a mini electric or a battery-operated one. Pain while pumping is something which is again, that needs a lot of troubleshooting. A lot of mothers believe that if they pump at a very high pressure, then they're going to release a lot of milk. That is not true. There are mothers who use any sort of flanges without actually realizing that they are not correct for their size. And we see that mothers, close to around 50% of them, need a different size than what comes with the breast pump kit. There's also breast edema from mothers who have PIH, a lot of IV fluids, and general fluid retention, especially if it's a mom who's been in trial of a normal labor for a long time and is then rushed into an emergency C-section. So if the pump is not used correctly, we do see a lot of nipple damage, blisters, abrasions, cracks, and injuries, and of course the enlargement of the nipple in the width and length. There's also a decrease in the milk supply. She can pump for longer periods but still not see anything. There is unrelieved engorgement, and all of this leads in a decrease in the number of sessions of pumping in 24 hours. What is the treatment in this situation? The treatment would be that she uses a little bit of hot water fermentation before pumping. She can use ice pack after pumping to relieve the pain. She can use olive oil or lanolin on the flanges so that the friction is reduced. She can also ensure that she is using the correct flange size. And there are special flanges which are flexible. They are known as personal fit or silicone fits. And this is what needs to be addressed more importantly. A good fitting flange will ensure that the mother's nipple moves in without any friction. It doesn't rub against the edges of the flange. If it's too small, the mother will have a lot of pain. And if it's too large, then the areola is going to get pulled in. Both the second and the third pictures don't help us with the pumping, so it has to be a good fit always. So there are different kinds of flanges, there are different sizes. So if you have a mother who complains of pain while pumping, you have to ask her to check the flange size. There are also soft silicone or the personal fit flanges that can be used. So relief from painful breastfeeding, engorgement, like I just mentioned, we can use gel packs instead of using the conventional hot water bags so that the mother is not put at a risk of being burned or dripping of the hot water on the breast, all of that. So just using gel packs. She can put the gel pack in hot water, it warms up, she puts it on the breast. She can use the same gel pack in the refrigerator, it will become cold and it's used as a ice pack. Inverted nipples are not very common. I know a lot of the medical fraternity thinks that inverted nipples are very common and are, troublesome when it comes to breastfeeding. But actual true inverted nipples are very rare. So in this case, if you're just dealing with a flat nipple or something known as a pseudo-inverted nipple, where on stimulation the nipple stands out, then you can use any of these three devices, which are very easily available. The nipple puller is better than the age-old method of using a 10 cc inverted syringe. And the before and after picture is of the niplet. So Philips is the most well-known brand in this product, but you do have local companies making this available as well. So generally with the niplet, you ask the mother to start using it in her last trimester. Similarly with the nipple puller, you again ask her to use it in the last trimester. If this is the case, you have to ensure that the gynec is involved and you're not doing this with a mother who has a poor obstetric history. So that's very important. So this small suction sort of a gadget that you see below fits on the nipple. And there's a small syringe which is attached towards the end, so that the mother has to pull out. It creates suction. She can wear it like this under her clothing for certain hours of the day and take it off when it causes any discomfort. When she does it for a period of 1 to 3 months, you'll find that the inverted nipple will get pulled out easily.
Why do you need the license permission for everything?
We don't need the permission per se, but there is research which shows that if there is very aggressive, and here I do mean the term aggressive, nipple stimulation in the last trimester of pregnancy, it can lead to contractions. So you want to ensure that you're not doing it in a mother who's had previous bad obstetric history.
After birth, you
After birth, you
can use
can use it, but then you'll see the results a little later.
But I don't need to check the breast in the last trimester.
There are two contradictory schools of thought where this is concerned. Most gynacs currently don't do breast checks. The mothers do get referred to lactation consultants, and we do it as a part of the antenatal checkup. But as far as I know, in Pune, we are not doing it. I don't know how the scene is here in Bangalore. Do most of the gynacs do breast checks antenatally? Would anyone know? I see very rigorous head shaking, so no, not sure. Okay. Okay, coming back to the presentation. So apart from the nipple pullers and the niplets, we also have the nipple formers and the breast shells. So if you have a mother who has a lot of nipple injury, then wearing a breast shell protects that nipple from being rubbed with her outer clothing. Similarly, if it's a mother who has an inverted nipple, she can wear the nipple formers, which are the second picture. It ensures that the nipple doesn't go back in. So she has to protrude the nipple out, wear the former, wear her regular clothing, and go about wearing the nipple former. So this can also be done antenatally. So the nipple formers we use antenatally, but the breast shells we'll use post-delivery. Yes. Nipple shield, everybody knows. I'll speak more about it towards the end of the session. But there are two types of the nipple shield that everyone should know. The contact nipple sheath has a slight cut at the bottom. that needs to be positioned such that the baby's chin can touch the mother's breast. It's to ensure that maximum skin-to-skin contact happens. But the full nipple shield doesn't offer any such benefits. So if you do have to recommend, then always recommend the contact nipple shield, not the full nipple shield. The breastfeeding pillow, I use it a lot in my patients who deliver twins. So you get a special breastfeeding pillow for twins and they can breastfeed the twins simultaneously. If it's a mother with a single baby and she's very comfortable doing it on her own, then the breastfeeding pillow need not be recommended. Benefits basically are that the mother can bring the baby to the breast, position the baby well, has good back support for herself, and it makes it easier rather than using the conventional pillows. Now we are moving to newer aids for babies, which I think will interest you more. So cup feeding is something that we do a lot at Cloud9 because we don't follow bottle feeding at all. Sir is very anti-bottle feeding and so am I. So we practice cup feeding. You have the nifty cups or regular cups which are available, and these are generally priced at around 880 rupees for around 10 pieces. So if you get one pack for your NIC also, that helps. This is easier to clean. There is no nipple confusion because the baby doesn't have anything that resembles a nipple in the mouth, and it helps in an easier transition to breastfeed. Would you be able to play the video? So I have a couple of videos for you. I'll play it once we finish the presentation. This video actually shows the baby drinking through the cup. Similarly, we also practice the bottle with spoon feeding. There are two kinds. This bottle with spoon is the one which has a hard plastic. The lower hand picture has a bottle with spoon, which is a soft silicone. Ideally used for giving semi-solid foods after 6 months, but if you learn the technique correctly, it can definitely be used to give milk as well. So I have a cleft palate baby here feeding by the spoon. Like I said, we'll play the video towards the end of the session. This is the cup feeder. The only drawback of this device is that it doesn't have a lid to cover it. This is from Medela. It's priced at 3,200. And it is an alternative to the regular cup and spoon feeding. It's easy, it's less messy. And the reservoir or the bottle that you see here has a marking. So you have a measurement to know how much milk is actually taken in and is going to the baby. This is the Haberman. So now known as the special needs feeder, since Dr. Haberman is no longer associated with this. So the Haberman feeder is what is typically recommended for a baby with a cleft palate, or it can also be used in babies with Downs or Pierre-Robin syndrome. Reason being, this part is known as a squeezable silicone reservoir. You fill milk in this, you turn the bottle upside down. By creating suction, you get the milk in the reservoir. The tip of the nipple has 3 slits, and the reservoir has 3 lines which actually denote the rate of flow. You have to position the nipple in the baby's mouth such that the line denotes how quickly the milk will go in the baby's mouth. And if you find that the baby is not able to generate a lot of suction, then you squeeze the reservoir, which actually ensures that the baby gets more milk than the effort the baby is putting in. So we'll see a video about this as well.
Transition from coverage feeding to
The soft cup feeder.
The cost is 3,000 plus. Otherwise, it's a very good alternative to the Katori Palada. Better than Palada, I think this has more easy to measure and it's very soft in the baby's mouth.
The only problem with the pallida is a lot of parents are concerned about it causing injuries in the baby's oral cavity, considering that it may be steel or silver. So they are very happy to use something which is soft silicone.
Soft would be hard economically for the
This is the supplemental nursing.
This I use a lot in my practice, but is not used much otherwise. So basically, any sort of top-up that you have to ask the mother to do, whether she tops up with formula or whether she tops up with her expressed milk, happens at the breast. So in this device, the mother wears a reservoir around her neck, and it has 2 thin tubes which come out from the top of the bottle here. If she's feeding twins, she can attach both the tubes to her both breasts and feed them simultaneously. If she's feeding a single baby, then only one tube goes into the baby's mouth. So you will find the picture on the breast where she is breastfeeding and she has put in a micropore which has taped the tubing. So we'll see a short video about this as well. The basic bit about this is parents get very annoyed when you tell them katori chamat se pilao. The minute you tell her, she's going to look for easier techniques, and that's when the bottle feeding begins and takes us far away from breastfeeding, which is our ultimate goal. Here, it can be whatever it needs to be. Can be formula if need be, can be the express milk if need be. I use this a lot in my patients who are surrogate mothers, where the surrogate has delivered, but it's the biological mother who wants to breastfeed. This is how we breastfeed. So we'll see a video about this as well. The other benefit of using the SNS is the mother who's actually wanting to breastfeed ends up increasing her milk supply because the baby is drinking at the breast. The baby is getting additionally supplemented at the breast, but the baby is sucking at the breast. So that helps. So if you know or if you have patients who want to relactate or who want to induce lactation, then this is one of the best devices to use. We'll see a video a little later. So who needs to prescribe or identify that the mother needs to use all these things? Someone who can identify the need, someone who can demonstrate effective usage, and someone who can wean off the aid. These are three critical points. So you can't simply just prescribe something and walk away. You ensure that you teach her the right technique and at the right time, ask her to take off the aid. This is my takeaway for this session. Nipple shields should not be blindly used for all. Please be very clear about it. The need, cause, and the correct size of nipple shields, as well as stopping use of nipple shields at the right time is very important. Incorrect use leads to a hit to the mother's milk supply. She doesn't understand that the baby is just doing pacifying sucking. So if you're recommending a nipple shield, you have to tell the mother to look for signs of swallowing, signs of adequacy in the baby. For breastfeeding to be 100% successful, correct latching is the key. Continuous breast pump use is not advised for a healthy mother-baby dyad. So if you're sending a full-term baby home with the mother, healthy mom, healthy baby, then of course she should not be pumping for the first 6 weeks because it can lead to oversupply and disrupt the breastfeeding. The last point is one of my favorite points because this is what the new registrars tend to do. Is the mother feeding well? We don't know. Okay, ask her to use a breast pump. Let's see kitna milk nikalta hai. This is the worst technique ever. So please do not use that. Using a breast pump to determine the mother's milk production is technically inaccurate. One single pumping session cannot tell you what the mother's milk supply is. This technique can only work in a mother who is only exclusively pumping, not in a mother who's breastfeeding. So do not use this as a means to gauge the mother's milk supply. Can I play the videos first? Because the next bit is the milk banking part of it. You get it in different sizes. So Pigeon is one company which has a size which is 13 mm, but Medela also has sizes which are slightly bigger. But then again, like I said, it's always better to not recommend a nipple shield unless you can teach the mother how to use it effectively. But yes, to answer your question, there are sizes available. You can play anyone, start with anyone. So this is the SNS. I have used a 6-number orogastric tube. It's connected to the mother's nipple and the baby is breastfeeding. It's a very short video because I couldn't upload the larger sized video. And we have kept the other end of the OGT in a bowl which is containing formula. Here we have supplemented with formula because the baby was not keeping well and had just had an episode of hypoglycemia. So this was our quickest way to actually give the baby a good feed. You can please play it again. So that's the tube here in the bowl. And you can actually see the milk going in through the tube. And that's the baby drinking and swallowing. If anyone is interested, I have the full video on my phone. Do not take pictures of these, please, because these are from my personal collection. Just till the nipple, not weigh in. You can play the next one. So this is a baby with the cleft palate and he's drinking on the Haberman feeder. Just needs a little bit of stimulation. And there you go. So this bit is the reservoir, the one which is just next to the baby's mouth. Because the baby is able to suck well, we are not having to squeeze the reservoir to give anything in. It's on the reservoir only. This is the bottle with spoon on the same baby with the cleft. Here you can see a little bit of spillage, but you can see that we are angling the bottle as the baby sucks. So we are adjusting the flow depending on how the baby sucks. And here we are using the hard plastic spoon bottle. Now we have just recently switched to using only the silicone spoons. So there's a small hole in the center of that spoon here, which is very clearly visible. You can take a video of this because this is not from my personal collection. This is a baby cup feeding, a term baby on day 4. This is from Dr. Jack Newman's collection. And you will find that the baby is held upright and they just tend to lap up the milk. You don't have to pour it in the baby's mouth. So you can use the Medela cups, you can use the Nifty cups, you can use a small medicine cup. The baby just needs to have a good suck swallow, like a good coordinated suck swallow, and giving cup feeding is a breeze. It's very easy. Very, very commonly.
So we see tongue ties very frequently and we do a lot of tongue tie releases as well. But what Sir and I have is a protocol where we try and see how long we can manage with what's currently happening. So we try and see for a week to 10 days to sometimes up to 15 days if the mother can get the latching well. Sometimes despite having a tongue tie, the baby can have very good uplifting of the tongue, very good lateralization of the tongue and good extension of the tongue. So if a tongue tie is such that it's not causing any issues with the usage of the tongue, then we most of the times get away with not doing anything at all. We find the baby coming back to us with good weight gain at each visit. But if it's a mother who complains categorically of painful breastfeeding, I can assess and see that the nipple injuries are worsening day by day and the latching is just not happening, then yes, we go in for a tongue tie release. I will just take 10 minutes to finish the milk banking bit. Okay, so we are now going to speak on the
banking part of the session. We've just finished with the newer rates. So what is basically a human milk bank? It is a service which collects, screens, pasteurize, and helps to distribute the donated breast milk to patients in hospitals or outside. I'm sorry, it looks like that. I think there's something wrong. These are the number of milk banks around the world. Of course, currently Brazil leads the lot. They have maximum number of milk banks and maximum number of collection centers. It is in fact a country wherein even bars have freezers on the side for mothers to just drop off the milk that they want to donate. They have firemen which pick up the milk and deliver it to the milk collection centers and the milk banks. So yes, they are leading, but India is currently on a mission mode. We have a lot of milk banks coming up in India. And in Pune, we are currently at 5. What would be the number here in Bangalore? Does anyone have an idea? There are 2 milk banks here. Okay. we just spoke about this in the previous session with the CLMCs. Basically, what has to happen is the human milk bank has to ensure that your unit becomes a unit which is mother's milk only. So either the donor milk works as a bridging till the mother is able to provide all the milk, or the donor milk works in situations wherein the mother's milk is unavailable. So it can be situations of giving up of the baby as well. So basically, milk banks have to be associated with larger hospitals, government setups, medical colleges, district setups, and such, wherein you have the stimulation and the expression support through electric breast pumps. You have the collection of the donor milk, storage, processing, and dispensing. So who gets to donate when and where? All mothers who are healthy and whose own babies are thriving well should be mothers who should ideally choose to donate. They should be free of infectious diseases, should have not received any sort of blood transfusions or blood products, not had tattoos or piercings for the last 3 to 6 months, and no history of multiple sexual partners or use of intravenous drugs. This is the same as the blood donation guidelines. Recipients of donor milk, again, since we've been speaking about prematurity since the morning, definitely preterms are the first recipients of donor milk, but we also have infants with other issues, like infants undergoing GI surgeries or having any other GI anomalies, like we spoke about the short bowel syndrome when we were heading for lunch. If the mother is temporarily unable to nourish her infant, if she is unwell, if she is hospitalized, you're weaning the child from parenteral nutrition, any metabolic disorders, or before the mother's milk comes in, which is why I mentioned it could be a bridging technique. So there are quite a few processes involved. We need to be a little informed about this because mothers who typically end up giving donor milk to their babies always want to know what are the processes involved. So they know that it's not raw milk going in. So the donor mother is registered and screened. Milk is expressed under aseptic protocols. There is collection and storage in the deep freezer. Pooling of milk is typically done at most milk banking setups, followed by pasteurization. Testing of the milk post-pasteurization to see if there is any bacterial growth or contamination. Anything raised to or anything more than 10 raised to 3 colony-forming units is not acceptable. Then that milk is discarded post-pasteurization, it is not used. Storage of milk at -18 to -20 degrees, dispensed on prescription basis only to sick babies. Guidelines, currently there are quite a few. We'll start with the Indian milk banking guidelines, which have come in from Dr. Ketan Bharadwaj. We have the Hambana guidelines, which are currently actually the oldest and the most updated guidelines. And since the NICE guidelines have been spoken about a lot since the beginning of the day, they have their own donor breast milk guidelines as well. Effects of pasteurization, this is a slide that I like to show because there are a lot of components of breast milk that change with pasteurization, which is why if you are a unit that uses a lot of donor milk, then you will have to ensure that you begin to fortify it at some point of time. Also, it's always a good idea to use a little bit of mother's own milk plus a little bit of donor milk, because the fresh mother's milk helps to catch up these other components which have just gotten destroyed in the process of pasteurization. Is donor milk safe? A very, very common question, again asked by parents. The second point is what you need to know. Ever since the history of milk banking and donor milk has come in, there hasn't been a single documented case of disease transmission through banked donor milk. But this cannot be said about informal milk sharing. So if you are a unit which uses raw mother's milk, you have to be very careful about it. But as long as you're using pasteurized donor milk, then it is fairly safe. So takeaway, human milk banks now are an essential service. You have to ensure that if your hospital can't have a milk bank of your own, then you're at least attached to a milk bank which can help you in times of need. India is now on a mission mode. Milk banking is a top national priority. Philanthropy and donations. What we need to know is protocols and policies regarding donation, dispensing, and record keeping are very vital. They need to be followed. And since we have the national guidelines now available, we can start using them. That's my last slide.
of studies in the recent past which have said that having a water shaker bath sometimes can have the added risk of the water seeping into the bottles. So if you're using a water shaker bath, then you have to use the bottle holders as well, which actually they are known as the cap sealers. They create a sealing sort of a mechanism between the cap and the opening of the bottle, which can sort of work as a preventive mechanism. But in the data that we see from Western countries, using a pasteurizer is expected to do better.
Our ministry says not to use the word milk bank. So when conferences are arranged by bodies like NNL, and so on, is it appropriate or should we just stick to cooperative lactation management centers?
See, you can call it a CLMC, but if you're not using it as a CLMC, it makes no difference. Right? If you're using it priority-wise only as a milk bank, you don't have any lactation management going on there, then you can't term it as a CLMC. You'll have to call it a milk bank.
Because myself and Pratik, when we were involved in the setting up of the National Milk Bank, the ministry was very clear. We should not use the word milk and bank together. So we changed the terminology. So bank means something that becomes commercial for countries such as India.
Yes.
I don't know what sir thinks about that.
I have no problem take laws on this because what is happening is some regulation on India will have 100 million.
There is no law. Or there has been no case against human being banking in the world. There is no case because there is no law. Who can file a case? There is no law only. There is no case also. Now we are pushing that there should be some law because online sales of human milk, commercialization that's going on, that has to stop. So that's why we are pushing for a law, and we in fact had a lovely debate in Nagpur on this, where we filed 5 cases on 5 doctors, hypothetical cases, and made them defend. And I say case ho gaya, to what will you do? And we are now writing an article on this, that the need for establishing rules, the medical legal aspects of it, but we don't want it to be commercialized. If your purpose is noble, then what you call it doesn't matter. So somebody raised an objection that no, we should not take money from Rotary. So one of the sponsors of International Rotary is Nestle. So we should not take. Let it be anybody's money. You are using it for a right cause. In fact, by using a human milk, you are going to displace their formula. To use their own money to displace their own product, problem kya? So just because Nestle sponsors International Rotary doesn't mean you can't take money from Rotary. And my boss used to say, किसी का भी पैसा ले लो, use it for a good cause. Money has no color. That's my boss. He took Hinduja's money, the Bofors guy, and created a PIC. He said, I don't care how Hinduja got it. I'm using it for poor people. Money has no color. My purpose is noble. Like I said, when I have Nestle may be sponsoring International Rotary because there is no IMS there. You can use Rotary money and have a human milk bank, but we are not selling formula. We are free human milk. So I have no problem with names, titles, or anything. Your purpose has to be noble. IMS Act will work only if it comes from the heart of the doctors. Opposing a law will not. Thank you. Very good. And you can share your number with them. If they have any questions regarding the products and what to use, what not to use, they can get in touch. So Dr. Nasreen, shall we finish your talk first before the workstations? We'll keep workstations last. Or do you want a tea break now, 15 minutes? And then we can finish up everything. Whatever you guys say. You must be ready for quick tea break. Maybe we can go and get the tea here. And then we'll have your talk and quick question. Okay with you? at tea time about corporates, adult physicians, pediatricians, and all that. So we'll start with a small joke, and then we'll have the talk and the work. So there's a small village in India that has taken a loan from the World Bank. And then you have to submit reports to the World Bank periodically. So the village people send a report to the World Bank that infant mortality is 0, neonatal mortality is 0, malnutrition 0%, immunization 100%, hospitals empty, no crime. The WHO says, World Bank sees the report. What nonsense is this? Report, first report, Indian village, 0% mortality, maternal mortality, 0, hospitals empty, everybody's immunized, nonsense. No sicknesses, no illness. So they send a group of inspectors to that village to find out why this people, how they fudge report, do a surprise check and find out what's happening. So the World Bank inspectors come and they go through the village. Hospitals are empty, clinics are empty. Door-to-door immunization reports all 100%. No malnutrition.
A very good evening, everybody. So we have discussed a lot about parental nutrition, aggressive enteral nutrition. So what about post-discharge? What's going to happen to these babies? Is it important? So as already Chanchal mentioned, the first 1,000 days is a very crucial period, especially for the brain growth of these babies. So post-discharge nutrition is very important. However, there is not much of evidence and there are no definite guidelines regarding these aspects. Hopefully, but by the end of the session, we'll get some answers and some clarity. So why is it important? Again, the first 1,000 days play a pivotal role in neurodevelopmental outcomes of these babies, especially if you look at this 40 to 48 weeks of post-conceptional age is the critical window. That means if the growth doesn't happen during this period, the baby is likely fall into a vicious cycle and it is less likely that the growth will be optimal later on, and thus it will have long-term neurodevelopmental implications. So ideal goal, of course, should be we should try to match the rate of growth and body composition of that of a normal fetus, which is probably not achievable. And hence, we should at least try to aim at achieving percentile parallel growth. Of course, as already mentioned, again, we should try to strike a balance between excessive growth and also at the same time avoid undernutrition. Sorry, this is very blurred. So if you look at the pic here, the blue bar here represents the recommended intake of the nutrients, and the green one is the actual intake which you are giving, and the red one is the deficit. So if you look at from day 1, there is a deficit, and when you go to day 2, there is a deficit on day 2 also, but it's a cumulative deficit of first 2 days. And similarly on day 3, it is a cumulative deficit of day 1, day 2, day 3. So as it progresses, the cumulative deficit is getting worse over time. And hence, by the time of discharge, most of our very low birth weight babies and ELBW babies have already got a significant deficit. And hence, you can't compare these babies to a term appropriate for gestation age babies. So these babies require more nutrients per kilo body weight compared to a term appropriate for gestation age babies. So what are the challenges? Mother's milk, undoubtedly, it's the best choice, but the availability is lower than recommended, both during the stay in the NICU and post-hospital discharge also. And what about fortification? As Veeraraghavan mentioned, fortification post-discharge is debatable. We'll discuss about this later. And when mother's milk is not available, what are the formulas options available? Especially in India, we don't have many options. So how to go about it? And what is the adequate timing of weaning? Should we go by corrected age or should we go by chronological age? So is it true the needs for normal growth are similar in preterm boys and girls? So that's a myth because boys grow faster in utero, they accrete more lean mass, and they also benefit more when they are given adequate nutrients both during the stay and post-hospital discharge. And many a times it is assumed that the needs for recovery are similar for all preterm infants, but that's not the case because the needs of recovery are variable and it differ from AGA and SGA babies. And also the smaller and more immature the baby is, the cumulative nutritional deficit at the time of discharge is more for such a baby. And hence such a baby is going to need more nutrients per kilo body weight. So before going to what are the categories of preterm neonates at the time of discharge, we should actually know what is the definition of EUGR. So there are two definitions, cross-sectional and longitudinal. So cross-sectional, as it mentions, at any time point, if the weight is below 10th, some guidelines mention below 3rd percentile, regardless of the birth weight, you would consider that baby as a UGR. So for example, if it is a SGA baby less than 10th centile at the time of birth, and at the time of discharge, though the baby has grown well, the baby is still less than 10th centile, but you would categorize this baby as EUGR if you go as per the cross-sectional definition. So what about longitudinal definition? Longitudinal definition means a weight loss of more than 1 or 2 standard deviations from birth to any given point of time. So you are actually seeing the growth of the baby over a period of time. And if it is altering more than 1 or 2 standard deviations, then only you would call it as EUGR as per longitudinal definition. So what are the disadvantages of using cross-sectional definition? It's based on only birth weight. It doesn't consider the other parameters like head circumference and length. And of course, body composition also, it doesn't take into account. It ignores the normal postnatal weight loss. So cross-sectional definition is not predictive of adverse neurological, neurodevelopmental outcomes also. And hence, it's better to use the longitudinal definition. So at the time of discharge, this is what all of us should be doing. Any preterm baby will fall into one of these 4 patterns. So we have either a appropriate for gestation age baby at birth or SGA baby at birth. And over the course of NICU stay, at the time of discharge, so category 1 is AGA baby at birth without any UGR. Second category is AGA at birth but with UGR. Third category is a SGA with early catch-up growth. And fourth is SGA at birth without catch-up growth. So as you all know, the first category is very, very exceptional. You would not find any such ideal situation where a baby is appropriate for birth and there is no EUGR. The second, third, and fourth categories are some things which we commonly come across. So once you categorize these babies at the time of discharge, how do they do after discharge? What is the pattern of growth? So the first category baby, if you remember, it's an AGA baby who has grown appropriately during the NICU stay and there is no EUGR. So these babies tend to grow normally subsequently. Again, this is very exceptional in clinical or day-to-day practice. So the patterns 2, 3, and 4, they do catch up growth by 2 to 3 years of age. However, if you see the AGA baby with UGR, they do catch up growth completely and in a more faster way as compared to a SGA baby who didn't have an initial catch-up growth also. So why is it important is, at the time of discharge, you have to categorize these babies and you should have an individualized approach for each baby. Not a single thing goes equally good for all the babies. So the requirements, as you can see, So the last one is VLBW post term, means after 40 weeks, that is the requirement. So it's no more 110 to 130. It's in general. If you don't take the parameters at the time of discharge into consideration. So a VLBW post-term baby, at term requires 90 to 100 calories. However, the protein requirement has come down to 2. But of course, it hasn't included, considered any UGR component during the stay into consideration. So we can't go by just this table. So what are the options available? The best option, of course, is human milk. But alone, is it sufficient? Do we need to add fortification? And what are the options of the formula available? So breastfeeding, our aim should be to send the babies on breastfeeding. And to achieve this aim, giving KMC, initiating non-nutritive sucking, all this enable breastfeeding at the time of discharge. So your success rate or your number of babies going home on breastfeeding increases. So ESPOGAN recommends if a baby is appropriate for gestation age at the time of discharge, you can continue to, you should send this baby on breastfeeds and add supplements whatever is needed additionally. However, these babies should be closely monitored. They should be called upon within 48 hours after discharge and then weekly. You have to monitor growth of these babies and you have to check all these biochemical abnormalities. And if anything needs to be supplemented, we have to supplement. What about human milk fortifier? Though it is a debatable issue, especially post-discharge, it is probably a practical and continuous option till at least a few weeks post-discharge for the babies who are sent on express breast milk by Palada because it results in better short-term growth. However, there are some concerns with the fortifier, especially if the baby is on exclusive breastfeeds. It is a difficult proposition to actually ask the mother to express milk, add fortifier. And there are some concerns that once the baby reaches term and beyond, you might be actually overdoing the thing. So these are the different formulas. However, the first one and third one, I'm not sure if they are available in India. As far as I know, they are not. No. So high energy formula is 1 ml gives 1 kilocalorie and the protein also is 2.5. So they are in the descending order in calories. High energy formula gives 100, preterm formula gives 75, post-discharge formula also called as transitional formula, it gives 75, whereas term formula gives 67. Proteins also, if you look at closely, they are also in descending order, except that preterm formula gives 1.9, whereas post-discharge formula gives slightly higher protein compared to the preterm formula. Why is it important? I'll let you know in the subsequent slides. Okay.
High cal. Okay. It's used in NICU, sir. So it provides high amount of energy and protein. But the main problem with high energy formula is there is something called
satiety mechanism. So these babies, you are providing when they are on ad-lib pills, even with small volumes of milk, they will achieve the calories whatever is needed. But at the same time, you are compromising the protein intake of the babies. So for a definite volume of milk, though the baby is getting adequate calories, the baby is not getting adequate proteins. So you won't be able to achieve that protein energy ratio for these babies. So this is called calorie satiety mechanism. So high energy formula we don't use. And coming to preterm formula, it is used in NICUs when mother's milk is not available. It has higher macro and micronutrients than term formula, but it whether we can continue to use it post-discharge, again, it's a big question mark. Again, the calorie satiety mechanism has got a role here because it could limit the volume. So as I said, the protein is 1.9 gram. So the baby end up getting less protein and probably more energy, which is probably not good. And Cook et al. Has shown that there is no impact on the neurodevelopmental outcomes when they assessed at 18 to 24 months of age. What is post-discharge formula? This is something which was available in UK. We call it as transitional formula. So these are designed for preterm babies only after hospital discharge. So for example, if a baby is on preterm formula and this baby is planned for discharge at around 35 or 36 weeks of gestational age, these babies are discharged on post-discharge formula or transitional formula. So though it gives 75 kilocalorie of protein, it ensures that the protein intake is slightly more as compared to preterm formula. So preterm formula gives 1.9, whereas the PDF gives 2.1 gram per 100 ml. So what is the evidence? The advantages of post-discharge formula is it gives more complete catch-up growth, greater weight gain and linear growth also. And also it improves the quality of growth. So it helps in the lean mass rather than the fat deposition. However, the main concern is commercially available preparations are not available in India. Correct me if I am wrong. Any such preparations are available, sir? Not available. So, and the use is not again supported by, there is some evidence, meta-analysis and Cochrane which has come up, which showed that there are no consistent effects of growth at 12 to 18 months. In the previous slides, whatever positive effects I have shown on the growth, they are in the immediate post-discharge period, but it did reflect the same later on at 12 to 18 months of corrected gestation age. And the lean body mass deposition also, it might be limited to only a subset of preterm babies who are appropriate for gestation age. Term formula, of course, to meet the demands of a preemie baby post-discharge, these babies might need somewhere around 240 or 250 ml per kilo of term formula, which is probably, not feasible. So these babies might end up with poor growth. So now what are the options available for us? I'll skip this slide. No, this one is important. So Conner et al., they have evaluated 3 sets of babies. So from birth to term is one phase. The second phase is they followed up these babies from term to 12 months corrected age. So there are 3 groups of babies. First group required fortified human milk. Second group preterm formula, and third received a combination of both human milk and formula. So when they were followed up till 12 months of corrected age, they were given either human milk or post-discharge formula, and the results are like this. So till term, the babies who are fed predominantly human milk, they are growing slowly. But after term, if you see the catch-up growth, especially with regards to the length and head circumference, the babies who are fed predominantly human milk for more than 6 to 9 months, they are actually doing well, especially in terms of length and head circumference. And they also showed a positive relationship between human milk feeding and the later Bailey Mental Index scale, as already I think Chenchal has mentioned. And the number of hospitalization days after discharge also has come down in the babies who received human milk. So this is how ESPGHAN recommendation goes. For human milk fed infants, at the time of discharge, if they are appropriate at that post-conceptional age, you continue to breastfeed these babies and add supplements as required. And if they are subnormal at the time of at the PCA, you continue to add fortification till they reach around 2 kilo or 40 weeks, whichever is earlier. And in formula-fed infants, if they are appropriate for PCA, you can continue the standard formula. So for suppose if you are discharging a 32-weeker baby at 40 weeks, these babies, if they are appropriate for gestation age at 40 weeks, they can be transitioned to term formula. But if they are suboptimal weight for the PCA, then here is where PDF is indicated till 3 months, sometimes till 6 months also. We used to use it in UK, but here, because there are no options, if the baby is not gaining weight well, sometimes we tend to continue preterm formula for 3 to 6 months. I think seniors like Umesh sir can add to it. Calories.
So at the time of discharge, if the baby is, if it is a AGA baby with EUGR, or if it is a SGA baby with no catch-up growth, then these two categories of babies will need more nutrients. So they need to receive either PDF or a preterm formula, because we don't have that option available in India.
Most of them we are only breastfeeding. So
Yeah, if breastfeeding is there, yes. Yes, sir. Yes, sir. That is debatable, but only thing is they advise to add supplements like vitamin D and iron, of course, as recommended.
So again, vitamin D, the recommendations are very varied. It ranges from somewhere from 200 to 1000. This is how the recommendations go. AAP recommends 200 to 400 for BLBW babies. ESPGHAN recommends 800 to 1000, whereas WHO recommends 400 to 1000, and it says during first 6 months only. However, we continue to use it till 1 year. And this is the IAP recommendations. Again, it recommends only 400 in preterm babies and neonates uniformly. And that's the calcium and phosphorus recommendations, which is calcium is 150 to 220 milligram per kilo. Okay, sir.
Okay.
800 per
But I called up and you can ask him why you are 400.
This is, I think, in 2017.
Yeah, he said we have changed it now. New guidance will be published soon. He agreed that we change.
With the present HMF available, so baby is receiving say 12 sachets per day. How much will be the vitamin D that will be going?
In fact, it contains 50 international units. So you should not exceed 8 HMS activity. Others will cross out.
Especially with the lactose HMS.
What we do is we tell the mother that 1 gram for 25 months with a maximum of 8 ml.
8 per day, sir.
8 per day max.
A also I think it overshoots.
Everything particularly what mothers use, they give some people petulant and they prescribe calcium. Some people prescribe vitamin D, bisphenol and calcium. So if you add all these bisphenol and bisphenol drops, we check 660 units per day. If you are doing bisphenol also, you can already do 660. Then you have vitamin D 800. Then you have a calcium preparation, complete everything. You should never cross 1000. So that's a toxic limit. So doctors is right, seeing that everything has vitamin D. So now I think we have bisphenol or calcium don't buy.
Freeman used to have a good, used to be much easier to titrate vitamin D with Freeman sachets. But they went out of market, sir. I'm not sure when they will be back.
But that because of COVID. Transport chain not affected. Once COVID goes, it is
However, I mean, recommends vitamin D, calcium, and iron, but it says daily oral vitamin A or zinc supplementation for the babies who are on mother's milk is not recommended routinely, because there is no much evidence to say it is beneficial. So vitamin D, calcium, and iron are the recommendations from the WHO. So growth monitoring post-discharge again is important. Usually after birth, they tend to track 1 to 2 centiles below the birth centile. But if they are going less than 2 centiles or tracking down further, then it is concern. And post-discharge, if they are crossing the birth centiles, either it means that they have not grown in utero properly and now they are correcting. But again, you should be cautious that you are not giving too much of nutrition, again, which could be deleterious. So the different growth charts available, I think now many units have started using intergrowth charts. Till what time you have to use either Fenton's chart is or intergrowth chart is again debatable. Some textbooks say after 40 weeks you start doing WHO growth charts, but whereas intergrowth charts, when you actually look at it, you can monitor these babies up to 64 weeks of PMA, which is when they overlap with the WHO charts. 64 weeks.
When do we expect a ELBW baby to regain the birth weight? Because when I was in UK, they used to regain by day 3, day 4.
I think in Indian units 10 to 14 days.
10 days, sir? Okay, about 10 days. Even ELBW babies, TPN 10 days, 10 days.
Complementary feeding again, would you just go by chronological age? If so, if you are going by chronological age, for example, for a 24-weeker baby who is born 16 weeks before, so you would end up starting complementary feeding for such a baby at 2 months of corrected age. So is that right? So how should you go about it? In general, they say between 5 to 8 months of chronological age and at least a corrected age of 3 to 4 months. Of course, you have to consider the developmental maturity of the baby, how are the oral motor skills of the baby before initiating complementary feeds. And you should not be in a hurry to just go by the numbers and start complementary feeds in these babies. So if you go by chronological age, you will be starting early.
Because of different population, so there is subversion. Studying subversion.
Okay, sir.
Social class now is very for correct is 4 months or 5 is 5 years. The paper is 5 months. Right. So I think not below correct is 4.
Yeah, 3 to 4 months is what they mentioned, but yeah, you have to assess the oral motor skills and developmental maturity. Yes, sir. So it requires individualized approach.
Take home, try to target percentile parallel growths, avoid both overnutrition and undernutrition. When it comes to post-discharge nutrition, immediately and also at the time of starting complementary feeds, it needs individualized approach. Breastfeeding, of course, is the best option. Use appropriate growth charts for growth monitoring. And yeah, the last point I already told. Thank you very much.
So now even IIP recommends that you start supplemental iron 10 milligrams per day for term infants from 6 months onwards. And now the new recommendation says that you have to give iron in a dose of 1 milligram per kilogram for 3 months every year after the birthday. From birth from 0 to 5 years. So 1 year, 2 year, 3, 4, and 5. So 3 months in a year you have to give iron supplement to all babies to prevent iron deficiency. But that's 1 mg per kg per day. So if the baby's 10 kilos would be 10 milligrams. So I started doing that because usually parents anyway insist for tonics. So better to give an iron rather than something else. So it is easy to teach the registrars 4 weeks for preterm and 4 months per term. Easy for unit to remember. And I started with that iron for 3 months every year in the first 5 years. But if you see, even the new NFHS study, the iron deficiency is more than 50%
even today. In our country, I think it's very relevant to give it.
This is this hydrolyzer master complex.
I use post NEC, post surgical NEC for a few days. And some units with diarrhea, period to 5 coming from outside. Those babies go mothers milk, then you can try having this problem. But there are very few indications. Thank you, very good. So I think
now videos about compounding and setting up a. So that will be the last part. We have skipped the enteral feeding case scenario and we have skipped the panel discussion because we had a lot of discussion on all topics throughout the day. So we'll wind up by 5 o'clock, so we finish on time.
Okay, so last workstation of this workshop, but very important, the practical part of the compounding we are going to see. So basically what we are going to see, initially let us discuss what a TPN room should consist of. So you need to have a compounding machine. So there are two types, 2x2 and 4x2. Two sizes are available, so you can use any. One UV connection should be there for the room and one UV connection is already there for the machine. Okay, then you need to have wash basin, you need to have dry storage, cold storage should be there, you need a computer and a printer to take printouts, and those printouts we are going to put in the file of the patient. Okay, so about laminar airflow machine, how do we maintain the laminar airflow machine, because it is the most important part. Okay, so what we do is we clean the laminar airflow machine with any disinfectant spray. We use aerodicin spray in NICU. So before and after preparation of TPN, we are using this disinfectant spray. So you clean all the 4 sides of the laminar airflow machine with disinfectant spray, and then you collect all the medicines which are required for the preparation. Will be on for 30 to 45 minutes. And after that, we will do the actual preparation. Now, what we do is we do the calibration of machine. Now, this calibration is done once in 6 months. So the biomedical people, they take the swab and also check the particle count, because there is an air filter which is set at the top of the machine. So you have to check whether it is working properly or no. If it is not working properly, there is no use of, using a laminar airflow machine. So you have to have a check on that also. Also, what we do is we do the monthly fumigation of the machine. Okay, and the machine as well as of the room. So that helps to maintain the sterility. So we are going to see the video of actual compounding of TPN. Now what we have done is, in this video, I have cleaned the bottles, I have kept, the UV light is done, and the actual preparation is, it is started. Now when you start preparing, the UV light will be off and the blower of the machine will be on. Now the blower is on right hand side. So you have, the fan should be on third level. So it forms a kind of blanket inside the laminar airflow machine. So no particles can enter inside the machine. Now see, when you're preparing, your hands should be inside the machine and the door of the laminar airflow machine should be open only 1/3. You should not open it completely. Okay? You should not remove your hands when you're preparing. Now, following the sequence of additives is very important when you're preparing the TPN. So step by step, we'll add all the additives. Initially, what I'm doing is I have taken the dextrose solution in the chamber. So when the TPN volume is less than 150 ml, that time you can prepare the TPN in the chamber, MV set. If it is more than 150 ml, you have to prepare the solution in the bottle. In that case, you have to discard the remaining dextrose and then you'll be adding all the additives in the bottle. Now with the help of 20 ml syringe and 16 number needle, I am going to put dextrose 50% first. What we do is we make small labels for all the patients, so there will be no confusion when you're making the TPN. Also, there are labels which are put on the bottles. So at a time, you can make 10, 15 TPNs at a time in a day. After dextrose 50%, we'll be adding amino acids. So amino and 10%. So we use either 20 ml syringe or 50 ml syringe can be used. You can use the same needle. Your needle should not touch the surface of laminar airflow machine. If it is touched, then you discard the needle and use the different needle. After amino acids, we'll add sodium. So we use concentrated RL. Next will be K-sol. So we use ampule cutters to cut the ampule, so there will be no glasses which will splatter. After that, calcium gluconate will be added. So basically we use only plastic bottles for preparing TPN. We are not using glass bottles. 50% magnesium sulfate. You have to be very careful when you add all the additives. By mistake, if you added extra or if you don't remember whether I have added sodium or no, you completely discard that bottle and set and again start with a new one. So all additives I have added in dextrose 10% and lipid will be given separately with the help of Y connector. Flush the line inside the laminar airflow itself, and then once everything is done, then only you go and attach it to the patient. For giving amino acids and lipid, we are using the double lumen Y connector, but this is an anti-reflux Y connector. So there are chances of mixing of lipid into the amino acid solution and amino acid solution into lipid. So this will help to avoid the mixing of both the solutions. So once the preparation done, the person who is making TPN, he will or she will only go and attach it to the patient. We will not give it to nurses or doctors to attach it. Yes, we use three-way also. So three-way, to that we will use the Y connector, and to Y connector a filter. Yeah, yes. But these are maximum, these connectors are only available.
Making it like a closed circuit. You don't need to disconnect it and again take it from a equipment. Hold one, please. There.
So while connecting, we remove the old tubings. We clean both the tips with the
heated in gauze or the spirit gauze. Then we'll connect the new one, and then after that we have to seal it. So if you seal it, no one will disconnect it for the next 24 hours. Even if they want to give anything else, it will that solution will be given separate line. TPN line will not be broken. So the sterile gauze and the betadine solution. And this will seal with the Tegaderm. Half Tegaderm is enough to seal. And after that, all the tubings will be covered with aluminum foil. Any doubts for compounding?
yes. It will be on.
So the basic purpose of UV light is to sterilize that area
Sterilize
prior
the
to.
area and all the medicines. Yes.
And what is the?
So we cover the lipid and tube. Yeah, with the help of paper or aluminum foil, we cover it with water. Then we keep it.
And what is this after life period of this UV light? Many of the hospitals it keeps on running. I mean, you won't check whether it is
So we
efficacious.
check it every 6 months.
6 months.
Yes.
Is it like any mapping or any specific relations?
But if for the no, only if there is a blackening at the side, that time you check.
Just want to know the practice of covering repeated loss. Really goes of
Yeah.
Yeah,
spirit or
Even chlorhexidine, the CDC says we can use a sterile dose. No need for chlorhexidine. This is CDC recommendation. But in our country, I mean, things are different. So.
For central language. For no, only W, not multiple. One for minus and one for resistance.
We use if you have a third, then understand. I put something from I will need to do this.
One has that anti-release. Polymer has the limited
To end of the workshop. Most important thing is that we started on the
Start.
Can use DEXA for that. So DEXA can measure body fat. But if you have the whole body composition, then you have to go for the P body. The P body can cost more than one. Small machine that you can carry in an ICU also put a baby in it. Cost your money. You try to that. And DEXA can assess body fat. I myself had a lot of fun today. I'm sure that maybe not be a part of presentations were very nice and most importantly they were very interactive. So that was the two purpose of a workshop that we had lectures. A lot of everyone participated. I only feel sorry for Pratik because he was part of the panel and he was breaking from the convention. We'll first solicit Abhijit. He's been sitting here all day and he's been very, very efficient. Do you want, I want to say anything? He's the main person driving all the thing and he's in touch time too many problems that we will keep a secret.
Thanks to Mr. Ajay sir. One thing you are very clear.
Please unmute yourself, Ritesh.
Of the room. So that helps to maintain the sterility. So we are going to see the video of actual compounding of TPN. Now what we have done is, in this video, I have cleaned the bottles, I have kept, the UV light is done, and the actual preparation is, it is started. Now when you start preparing, the UV light will be off and the blower of the machine will be on. Now the blower is on right hand side. So you have, the fan should be on third level. So it forms a kind of blanket inside the laminar airflow machine. So no particles can enter inside the machine. Now see, when you're preparing, your hands should be inside the machine, and the door of the laminar airflow machine should be open only 1/3. You should not open it completely. Okay? You should not remove your hands when you're preparing. Now, following the sequence of additives is very important when you're preparing the TPN. So step by step, we'll add all the additives. Initially, what I'm doing is I have taken the dextrose solution in the chamber. So when the TPN volume is less than 150 ml, that time you can prepare the TPN in the chamber, MV set.